Very official. We've done the countdown. Great. Thank you. Welcome, everyone here in the room and online. Welcome to the Data Exchange Framework Stakeholder Advisory Committee meeting number 3. My name is Athena Chapman. I'll be working here today to help facilitate this meeting. You should all be familiar if you've attended before, but welcome to everyone. And we're going to just jump on in because we've got a lot to cover. So before we get started, I just want to highlight 2 important reminders for anyone who is participating virtually as a committee member. First, committee members that are participating virtually, you are expected to keep your cameras on throughout the meeting. If you need to briefly turn your camera off, please put a note in the Zoom chat to let us know. Technical issues are the only reason that committee members should remain off camera for an extended period of time. Second, if you are participating virtually and posting comments in the Zoom chat, please make sure you are sending your comments to everyone rather than hosts and panelists so that members of the public are able to see your comments. Thank you for helping us ensure that today's meeting remains open and accessible to everyone participating. So next slide. We're going to quickly just run through the agenda for today. So we're going to open up with some welcome introductions, an official kickoff. We have some department updates from the director. And then we will go into specific HCI DxF program updates. We have some time on the health-related social needs and some special guests today to share some information with us. We will then talk about the QHIO program and 2 parts, and then we will have time for public comment, and then we have closing remarks. There will also be opportunities for public comment after each agenda item. So lots to get through, but lots of good conversations to be had. So with that, I will hand it over to Dr. Jennifer Sales, who is our committee chair.
All right. Good morning, everyone. So at 10:02, we are calling our 3rd meeting to order. Thank you for being here. I'm Jennifer Sales. I'm the chair of this committee and appreciate everyone's time and energy making it up here and spending the day together on this very important topic. So I need to do a quorum before we begin. And so I will call folks off. Let me know if you're here. Joan Allen.
Present.
Bill Barcelona.
Here.
Colleen Chawla.
Here.
Yvonne Chung. David Ford. Aaron Gooddale.
Here.
Katie Hydorn. Andrew Kiefer.
Present.
Scott McDonald.
Here.
Okay. Oh, okay. Scott's virtual. Yes, that's right. Oh, Katie Hydorn. Thanks. Ali Motoresi.
Here.
Eric Nielsen.
Present.
Lucy Sains.
Present.
Mark Savage.
Good morning, present.
Kieran Savage Sagwan. Jennifer Sales, I'm here. Julie Silas. Lee Tien. Okay, those are our voting members. Got a couple of folks not here, David and Lee. Ex officio members, Elizabeth Bassnett. Okay, Rebecca Fisher. Oh. Rebecca, you're online?
Yes, I have. Thank you.
Okay, thanks. Amanda Levy. Jana Lauder Blanco. Anna Nakamura. Or sorry, Ann Nakamura. No. Taylor Priestley.
Charles Rye here online for Taylor and covered.
Great. Hi, Charles. Shannon Rohal. Okay. Lynette Scott.
Present.
Jared Shoneberry.
Present.
Excellent. Okay. Thank you all. So I wanted to welcome a couple folks at the table before we get started. Hopefully Alana's coming back to the table. We have some guests today. Very excited to have folks here to share some of their experiences as Athena put out around health-related social needs data. So we have Alana I'm going to say right. Say Kalinowski. interoperability solution architect, and Cami Christensen, Chief Business Development Officer, and both of them are with 211 Community Information Exchange San Diego. And they're going to be presenting later this morning, as Athena pointed out, on agenda item number 4, on individual level demographic data and health-related social needs. So thank you both for being here, and appreciate your time. Looking forward to your presentation. And before we jump in, I will pass it to Akira for a little more housekeeping.
All right. Thank you, Dr. Sales. Hello, my name is Akira, and I'll be in the background to support with today's meeting, both on-site and on Zoom. Live closed captioning will be available. Please click the CC button to enable or disable. We will conduct today's meeting in accordance with the Bagley-Keene Open Meeting Act. Members of the public can participate in person or virtually and provide public comment via either platform. Meeting materials will be publicly made available, and minutes will be prepared and posted following the meeting. Public comment will be taken at a designated time during the meeting. The committee chairs will call on individuals in the order in which their hands were raised. Individuals are encouraged to limit their time to 2 minutes. Individuals may, but do not have to, state their name or an organizational affiliation at the top of their statements. For advisory committee members who are on site, you may join the meeting through your respective panelist link because the room's camera will not be able to pan to you when you speak. We ask that you keep your laptop audio off during the meeting. If you wish to speak, please make sure the microphone in front of you is unmuted by looking for the green light. When you are not speaking into the microphone, please make sure it is off. Wi-Fi and technical instructions are posted in the room. Participation will vary slightly depending on how you are joining the meeting. For members who are on site with Zoom, use the raise hand feature. Raise your hand physically or stand at your name card on its side. Those on site without Zoom, please line up at the podium and wait to be recognized. For virtual, use the raise hand feature and accept the prompt to unmute when called. For phone participants, use the phone keypad to raise your hand and unmute when prompted. Those dialing in can press *5 to raise your hand. When called upon, please wait to be unmuted before speaking so everyone can hear you clearly. Finally, additional details for on-site and off-site instructions are included on the slide. Thank you, Dr. Sales. Back to you.
Okay, great. So everyone received minutes from our last meeting in the pre-read packet. So we're now looking to approve the minutes. Do I have a motion from anyone to approve the minutes from our last meeting?
Mark
Number 2.
Savage, so moved.
Thanks, Mark. Second?
Second.
Thank you, Lucy. Okay, excellent. So before we go to public comment, did anyone have anything they wanted to bring up, comments, reflections, perspectives on those meeting minutes and discussion before we keep moving? Okay, looks good. All right, so now we're going to go to public comment if there's feedback on those minutes. I'm going to read this once just so everyone's on the same page about how the public comment works, and then I'm hopeful you won't have to listen to me read it every time. So we can have a good public comment process. So for those of the public, so that we have equitable access to verbal public comment, we're going to alternate between members virtually and in the room. If you're in the room, please come up to the podium. And if other folks are up there, please line up and we'll go back and forth. If you are on the phone or the virtual meeting, you should click the raise hand button. And if you're dialing in, you can actually, and not on video to raise hand, you can do a *5 to raise your hand. And we will be tracking the order in which your hands were raised and then alternating accordingly. I did also want to note, folks are definitely encouraged to limit their comments to 2 minutes or less so that we have time to hear from everyone and as many people from public as possible. You do not have to state your name and organization affiliation at the top of the statements if you do not want to. And please also just note that while this committee is committed to communication and transparency, the committee members are not going to be responding directly to public comment at the time. They will be listened and be informed by the public comment. And additionally, the committee may not discuss or act on any matters raised during the public comment period that is not included in the meeting agenda, except to decide to place it on a future agenda. So it'd be great if you could reserve your public comment for the agenda items first and foremost. So any public comment on the meeting minutes?
There's no hands raised at this time.
Excellent. Thanks, Akira. Nobody is in the room. Okay. All right. So this is closed. Okay. Okay. Now we are going to have a roll call vote to approve the minutes. So I'm gonna call you out. Please answer yes, no, or abstain. Joan Allen.
Yes.
William Barcelona.
Yes.
Colleen Chawla.
Yes.
David Ford. He's not here. Aaron Gooddale.
Yes.
Katie Hydorn.
Yes.
Andrew Kiefer.
Yes.
Scott McDonald. He's virtual. Yeah. Okay. Ali Odessa. Okay. Eric Nielsen.
Yes.
Lucy Sands.
Yes.
Mark Savage.
Yes.
Kieran Savage Sadwan. Jennifer Sales. Yes. Julie Silas. Yes. Lee Tien. So Scott McDonald, are you on?
Yes, I am now. Yes. Sorry, I just got through
Thank
security
you.
at the airport.
Okay. Thank you for hanging in. Okay, great. All right. So appreciate everyone's vote on that. And I think we are in order. The motion passes. And now I'm going to Director Landsberg for some updates.
Thank you very much, Dr. Sales. Good morning, everyone. Thanks so much for being with us. So as is our custom at HCI at our public meetings, I'll share a few updates from around the department that may be of interest to you. So it being August, we just have a new fiscal year that started, and I'll talk a little bit about some of the budget components related to HCI that may be of interest. We received funding in the budget to provide support for gender affirming care and reproductive health care, both some uncompensated care funds and some provider support funds as we continue to support those critical services in California despite federal threats, including a new Medicaid rule that came out this week. Behavioral Health Services Act under the BHSA Proposition 1, 3% of those behavioral health funds come to HCI to support workforce investments, and so there is a piece in the budget about that. CalRx. So the governor just announced this morning that we will be providing free albuterol inhalers to all schools. So this is our third CalRx product following insulin and naloxone. So each school will get 2 free inhalers and then 25 spacers, so the same kid can not share germs if there are multiple children in respiratory distress. And we're focusing on albuterol because of the high 1 in 8 children, school-age children, have asthma, and of course some children don't have inhalers with them, and so really critical to have access. So we were pleased to work with the Department of Public Health on this and the California School Nurses Association, who are providing training to school nurses on this. So excited about this CalRx product. And then the budget includes our next couple of CalRx products, which will be EpiPens, which are very artificially inflated, and tuberculosis drugs, more of a public health focus there. We're very pleased to have ongoing funding for California's all-payer claims database in the budget, the healthcare payments data program, and many of you in this room are great collaborators with us on HPD work. So we're excited to continue to provide that data and to start collecting data from PBMs this year. And then for distressed hospitals, the budget includes, so I talked last time about how we had just implemented a $25 million kind of small grant program for distressed hospitals. The budget includes an additional $90 million for distressed hospitals, and in grants, as previously we had a loan program, and this year we're looking to grant programs. And then the budget also includes $10 million for HCI to establish a new healthcare stability unit to evaluate hospitals' strategic importance to their communities, assist in planning for maintaining critical services in the event of financial distress, and then providing technical assistance to currently distressed hospitals. So looking forward to digging into that work and continuing to support hospitals. Rural health transformation is another hot topic that I'll just share a few updates about. Again, this is the $50 billion in HR 1 for rural health, to support rural health sustainability. And we were awarded for California $233.6 million, and we're excited that the RFAs have finally started to come out. So we just last Friday received applications for the accelerator partners. Huge interest and demand for that program. I believe tomorrow we have the deadline for the EHR, electronic health record. Well, you all know what this room knows what EHRs are. The EHR grant program closes tomorrow, and then on July 31st we have our workforce recruitment retention, and there's a third R. What's the third R, Mike? Program that's ending. So the RFAs are coming out. We're very proud of the team's work, and it's been really helpful to be in rural communities and to hear, most importantly, to hear from the clinics, the rural hospitals, the tribal entities that are providing services. I came immediately just before this meeting from a tribal consultation. We have a 5% set aside for tribes, and we're hearing from them about how to best use those dollars. That is a floor for them. So we also in this room, no, not in this room, it was virtual. We had the first meeting of our Rural Health Policy Council to again really listen to the community and try to use these dollars most meaningfully. So those were most of the pieces that I want to touch on this morning, and happy to take any questions if there are any, Madam Chair.
Excellent. Thank you. Do we have, any questions, thoughts for Dr. Landsberg, for Director Landsberg from the committee? All right, Lynette.
This is Mark Savage with a raised hand.
Oh.
Okay to go?
So Mark, no, you're second. Lynette's speaking first, then we'll come back to you, okay?
Okay, sorry about that. I was just going to say, congratulations. And it's really huge, the funding for the HPD. I mean, the fact that California has an all-payer claims database is incredible. So wanted to congratulate and say thank you for all the leadership over the years. I'm really thrilled. And I love the fact that I'm able to direct researchers to this incredible resource that's even better than Medi-Cal by itself.
Thank you so much, Lynette, and we appreciate your steadfast collaboration on that. And many folks in this room, I think many of us were in meetings, 20 years ago. CHCF was sponsoring, like, what is an all-payer claims database and how could California do it? And so it's really great that Mike's team is publishing a lot of data, that you're able to refer researchers to us. Keep them coming. We want the data to be used. And Mark, now.
Yeah. Mark, would you like to?
Thank you. Not quite getting the cadence. Really appreciate the update. From personal interest, I happen to follow what's going on with the wildfires around indigenous nations and other rural areas. And I'm wondering if the department is tracking the potential impact of those wildfires on providing health care and perhaps changing priorities in providing health care, especially, say, environmental issues. Thanks.
Thanks so much for the question, Mark. And yeah, it's so heartbreaking to see and hear of the wildfire impacts. Mike and I were just in the rural north earlier, a couple weeks ago, and yeah, very aware of that. So I think again, we're trying to listen and learn from our partners. I appreciate you raising the issue. I think we definitely will keep it on our radar. I think we are very much focusing on primary care, chronic disease management, maternity care. And so we need to realize that primary care and the impacts to chronic disease are changing with the many impacts of climate change. And so really look to partners to hear what the need is and appreciate you flagging the issue.
Thanks so much.
Great. I think just for, since we have a split committee, virtual and in room, if you're in room, if you can put your card on the side, if you want to ask a question, and put it down when you're done. And then if you are online and on the committee, I guess Scott and Mark, if you all could raise your hand if you want to say something, and we'll have the folks are watching you, so we'll call on you just so that because you can't tell what's happening here. So anyone else have thoughts, questions for Director Landsberg? Well, thank you.
Thank you.
Appreciate it. Oh, okay. Here. Do a little flip. Okay. So next we have public comment. Any public comment on the updates?
No hands raised at this time, Doctor. Oh, we got one.
Okay.
Lucy Johns, you can unmute now.
Thank you. I have been reading about the federal government attempting to access state healthcare databases for their own purposes. I'm wondering if you could inform us, especially those of us not in Sacramento, how that interrogation has been playing out in California.
Thanks very much for the question. I think we've been having those conversations within California about how to best protect vulnerable, sensitive patient data. So HCI, Mike, right, there's no impact to HCI data from the federal government. And Dr. Scott, I don't know if there's anything else you want to say on the Medi-Cal side.
DHCS has information on our public website related to questions about data sharing associated with the federal government and others. So happy to, direct you to that location as well.
There's also no other hands raised at this time, Dr. Sales.
Well, I just want to note, I just made a mistake by responding to public comment. So my apologies. So we appreciate your public comment. This is important to us to have the public meeting. And so we'll respond to public comment after the meeting if we're able to do so.
Great. Thank you. Okay. I think we are ready to dive in to today's agenda. Mike Valley is going to kick us off. Thanks, Mike. Over to you.
All right. Thank you, Dr. Sales, and good morning, everyone. I just want to say a few words by way of introduction and programming for today's agenda. You can go to the next slide, please. Senate Bill 660 includes two separate but related requirements on two different timelines for this committee to make recommendations and provide input to HCI. One is for the advisory committee to collaborate with HCI on the development of a report to be submitted to the California legislature by July 1 of 2027, with recommendations about various topics to evolve the data exchange framework, including compliance and enforcement approaches, new entities that are not currently participating in the data exchange framework that could, and more. And then secondly, the committee shall also make recommendations related to demographic and health-related social needs data, specifically for statutory changes, training and technical assistance, and best practices to require and support the collection of these data and to advance the goals of the data exchange framework. You'll see that based on your feedback, we agendized time to discuss the health-related social needs data item at the August meeting today, and then in October and December as well, to be able to complete the recommendations by the January 1 deadline. Today is introductory to level set, share information and experiences, and would expect the committee would get more into solutions at the October and December meetings. I'd like to also thank our invited guest presenters from the California Pan-Ethnic Health Network, Alameda County Health, and 211 San Diego. Thank you so much, Cami and Elena, for joining us here in person and to help inform the committee on this important issue. So that's all part of agenda item number 4. Next, we will continue our discussion of the Qualified Health Information Organization program and its evolution. We discussed specific areas for improvement at the last meeting, and today we'll be diving more into the potential solutions. That is agenda items number 5 and number 6, and there will be opportunities for public comment after each of those agenda items. I also want to thank everyone that was able to join the July 16th Data Exchange Framework webinar that was designed to give the committee and the public the opportunity to learn more about happenings from across the country related to health information exchange, and specifically on approaches to event notification, and to allow for that to occur in between our scheduled meetings. And so thank you to our invited guests from the states of Massachusetts, New York, Maryland, and North Carolina, and also to the patient-centered data home group for sharing their experiences. And I think that'll be very helpful to inform today's discussion and our ongoing dialogue as well. A recording of the webinar, along with other information, was included in the pre-read materials for members, and it is also posted on the Data Exchange Framework website for the public. And then finally, before I hand it over to Jacob, this committee also discussed ways to address other issues important to the Data Exchange Framework beyond the requirements of Senate Bill 660, and how to engage other stakeholders and experts outside the committee, recommending at the last meeting that HCI convene a technical work group focused on providing input on a roadmap for FHIR data standards adoption, and that after the work of that technical work group is complete, that this committee would then subsequently consider their input. So you'll see on this slide of committee discussion topics that we included an indicator for when that work group will be conducting its work, and then after when we plan to agendize review of their work by this committee. You'll recall at our first meeting in April, developing a roadmap for FHIR adoption was the top priority strategic initiative amongst 6 others that this committee prioritized that weren't specifically required by Senate Bill 660, but that this group believes is important to advancing the data exchange framework. With that, look forward to another fantastic meeting, and I'll turn it over to Jacob Parkinson. Thank you.
Thank you, Mike, and we can go to the next slide. Good to see you all here today. As Mike mentioned, we are convening our 2026 standards work group to start informing the roadmap for FHIR adoption. The work group is going to be asked to advise on a number of different key areas, including adoption strategies, DxF use cases, how we might mitigate costs associated with this, how we might transition from legacy standards, and starting to set an overall timeline for adoption for DxF participants. Now, we intend to select about 15 members for this work group with specifically practical, technical, and operational FHIR implementation experience. That is what we're looking for in this group. And we hope that this group will represent DxF participants, intermediaries, vendors, and other stakeholders. Now, this group will meet virtually about 6 to 8 times starting in October, with the goal to start bringing consensus advice to HCI by early next year. And we will bring the roadmap to you in the spring of next year for your review and input. These meetings will be open to the public, and we'll be posting the materials to our webpage. So we encourage you to follow along. We may also bring summaries to future meetings here. One important note, per Bagley-Keene, no more than 2 stakeholder advisory committee members can serve on this work group. So if you are interested, I would just encourage you to consider whether you or another member of your organization might be best to serve in the work group. The application is available on our webpage, and it is also linked here on the slide. They are due August 31st. So please do get the word out, and if you're interested, apply. We can go to the next slide. We are going to dive into some conversation on public accountability and enforcement. But before we do, I just wanted to share 2 brief updates related to policies and FAQs. As I mentioned in April when we first met, we are publishing a substantive amendment to our participant directory policy and procedure clarifying when participants who've elected to delay exchange must go back into the directory to update their choices. We had heard from some participants that the language was confusing, and so we are clarifying that language. We are also pairing this with a couple of administrative amendments to align with newly defined terms. And as with all substantive amendments, these will go out for a public comment period. Once we post them, members of the public will have 45 days from that posting to submit their comment or questions. We'll have a standardized template on our webpage, and you can submit it to our DxF email. Once that amendment is finalized, as with all policy updates, participants will have 180 days before they actually take effect, and participants are held accountable to the new requirement. Okay, the second update, as a in response to a number of questions we've been receiving, we are updating our FAQs. FAQ number 1, who is required to sign the data sharing agreement? We are clarifying which clinics are required to sign. And we are also drafting a new FAQ to clarify that organizations cannot sign the DSA on behalf of a contracted organization who is required to sign. These FAQ updates will be published soon. And with those policy and FAQ updates, we can jump into accountability. So let's jump to the next slide. Today, we are simply going to be sharing a brief update on the work that we've been doing thus far. As you can see on the roadmap, we've set aside a fairly significant amount of time to really get into enforcement and accountability of the DxF. In the future, we plan to discuss DSA signing compliance rates. We plan to discuss our non-compliance listing, purchaser contracting requirements, and potential frameworks for long-term enforcement and accountability of this program. Let's go to the next slide. As just a brief reminder, Assembly Bill 133, which stood up this program in 2021, did require certain health-related entities to sign our data sharing agreement. SB 660 last year provided some more precise definitions of physician organizations and medical groups and began requiring emergency medical services to sign the agreement. Our most recent deadline was July 1st, 2027, where medical foundations and emergency medical service providers were required to begin signing. Let's go to the next slide. We have seen a fairly significant uptick in signatories to our data sharing agreement, specifically between June 1st and July 14th, likely as a result of that compliance deadline I referenced. Over 500 entities signed the DSA during that 6-week time period, many of which were medical foundations and emergency medical service providers, though there were other entity types that were signing. And we're going to discuss this soon, but we're hoping to see this number continue to rise quite dramatically as we begin some concerted outreach efforts focused on accountability throughout the remainder of the year. And at our October meeting in 2 months, we're going to start discussing initial compliance rates for the different entity types. So you'll get a preview of where we're at with compliance before we head into posting this list to our webpage. We'll go to the next slide. We also wanted to update the committee on some recent changes as a result of the Health Budget Omnibus Trailer Bill, Senate Bill 164, which extended the deadline for certain entities to sign the agreement. This specifically applies to community clinics, intermittent clinics, and rural health clinics. And we have since updated our policies and procedures and FAQs to reflect this change in the statute. Next slide. Okay, so as a reminder, Senate Bill 660 called out a number of new accountability measures to be taken by HCI. The first of which was to publish and continually update a list of non-compliance. This is specifically organizations who are required to sign the DSA who have not yet done so. And the second item tasked by the legislature is for us to submit the report to the legislature as Mike mentioned, that includes a list of organizations who are required to sign, their signing status, and whether they or not they have a contract with the purchaser, an evaluation as to whether other categories of entities should be required to sign, and an evaluation of whether we need additional frameworks for enforcement, dispute resolution, or investigation in this program. As we noted in a previous slide, these conversations will be brought back to the committee for a far more robust discussion at a future meeting. We're really just looking at the steps that we've taken to start preparing for that first one, the non-compliance posting. We can go to the next slide. Specifically, to prep for this non-compliance list, we've published 3 resources to help stakeholders understand who is required and how to work with HCI to resolve any issues. First, we published a required signatory methodology, which outlines the specific data parameters we are using to build a denominator of required signatories. These denominators rather, are really built all using public data sources and informed by stakeholder feedback and input, including input from a number of the different state associations. We will plan to continue to update this methodology based on feedback from the public and feedback from our government partners. And we plan to discuss this with you all in more detail in more October, as I mentioned. Let's go to the next slide. The other 2 resources we've published are intended to support entities that we've defined as being out of compliance. So first is a non-required signatory attestation form. This form can be submitted by entities who want to attest that we've got it wrong, that they've already signed the DSA, or that they believe they are not required for one reason or another, and to explain to us why that is. And second is a form for submission of statements of extenuating circumstances. These can be submitted by entities who acknowledge that they're non-compliant, but want to share some reasoning behind their circumstances affecting their ability to comply. And we will publish those statements along with our non-compliance list coming later this year. We've also published some standard operating procedures describing our intake process with these forms and timing expectations for us to handle submissions of these forms. Let's go to the next slide. And finally, on this, I'll close with a reminder that we are starting a large outreach campaign to organizations across the state who are unsigned, who we believe are required to sign, and helping them understand their requirements. This is a phased multi-channel outreach campaign. And I want to start by just thanking the state associations who have helped collaborate with us to start getting information out the door to their member and provider communication channels, help get our education materials out, to help spread the word on our non-compliance posting deadline. We've also been in active meetings with regulating agencies, so I want to thank them for their collaboration, and we're exploring opportunities for them to help spread the word as well. This month, we actually started that outreach to select entities, acute care hospitals, plans, and we are heading into the big ones with physician organizations, medical groups, and EMS, and more later in the coming weeks. And all of this outreach will go through December as we prep for posting this list. If there are any questions on that public accountability work, happy to take them. If not, I'll transition to Jennifer for a public comment.
All right. You got off easy this time, Jacob. Okay. Everyone's saving up for later in the agenda, perhaps. Okay, a couple quick things before we go to public comment. One is, Yvonne, somehow you are not on my list that I was reading, so apologies. Yvonne has been here. All right, she didn't even know that I forgot to call her name, but Yvonne has been here. She's here from the beginning, so that's excellent. And then I think, Shannon, do you want to just introduce yourself real quick?
Yes, there we go. Thank you. Shannon Rohan from CDSS. I oversee a team that manages technology projects. So happy to be here.
Great. Thanks for joining us as an ex officio member. All right. So we are going to move into public comment. I will start in the room if you can queue up, and then we'll go alternate with online. All right.
Green is on.
Green is on. Yeah, there you go.
Ann McCallum with Intrepid Ascent. A really brief one, a great presentation. I'm wondering, and I just haven't been in the weeds recently, is non-required the same as voluntary? And if they are, has voluntary been revised in the PNPs or kind of crosswalked? little nit.
Thanks, Deanne, for the nuance there. We'll take that back and make sure to clarify.
Okay, I guess Mark, you're online. Did you have a comment?
I am. It's not public comment. It's actually responding to your earlier question about whether there were any questions of Jacob. And this question comes from my focus on both sort of signing things, but also using them. So I picked up Jacob on the fourth point about education and outreach. And I'm wondering if you could say a little bit more about that education process, the content of it, to so that people are not just signing, but they're also using to their ability. Thanks.
Really excellent question, Mark. The way we see it, there are many steps to compliance with the framework. The first is getting folks committed by signing the agreement, but we certainly don't stop there. We think the next step is to get connected to appropriate technology or intermediary partners, and then to really be exchanging data. We are laser focused on getting folks committed, largely just making them aware of their requirement to sign, but also their requirements under the policies and procedures to exchange data in real time with other participants. So our education and outreach is really focused around, hey, there is a requirement to sign, and when you sign, you are held to these specific requirements under the policies. So that's our focus immediately, and there is more work to do on top of that.
Thanks much.
Okay. So any other public comment in the room? No. Akira, any other public comment online?
None at this time, Dr. Sales.
Okay, great. All right, so we are going to, thanks for that update, Jacob. We are going to go back to Jacob to dive into the individual level demographic data and health related social needs data conversation. And this is where we are delighted to have guests both virtually and in the room presenting some sort of real life examples of how this is happening and where this is happening and how it's going. So Jacob, I'm going to pass it over to you.
Thank you much. And yes, we have a bunch of wonderful guests who get to do a bunch of wonderful sharing in this section. But I'm just going to lay a little bit of a foundation before we start. So this is the beginning of another series of discussions, committee discussions, that's going to inform recommendations required under Senate Bill 660. Mike mentioned it at the top of this call. We have a statutory charge ahead of us here with these recommendations. Our goal today is not to get into recommendations or really just talk about the current state landscape, including existing policy and standards, what we know about how this information is being collected, some practical experiences of folks on the ground working with the data. We're not looking to finalize recommendations, but we do want to talk about key issues and opportunities we can bring to October as we prep for recommendations to the public. With that, let's jump into some framing. Let's go to the next slide. I want to just ground today's discussion in the statutory charge. Mike really covered it, but just want to highlight three things. This recommendation is really focused on training and technical assistance, best practices for data collection, and potential statutory changes. And this really is quite a broad charge that we're tasked with. So we just want to start to set a common foundation of what we're trying to talk about and cover here before we go out and start producing these recommendations. Let's go to the next slide. So one important distinction we want to call out before we jump in is the difference between data collection and data exchange under this program. Existing DxF requirements generally require participants to exchange data that they already maintain when it's permitted by law. And participants have some flexibility in how they do that exchange. They can use any technology or vendor or HIE they want. We also do not currently require participants to collect demographic or HRSN data that they do not already maintain. We also do not prescribe single demographic questionnaires or HRSN screening forms or things of that nature. So really the key takeaway here, the DxF establishes expectations for the exchange of available information, and we do not today determine what data organizations must collect that they don't already have. And that distinction is important as we start getting into our recommendations. We'll jump to the next slide. At the same time, there are some federal standards that help define how demographic and HRSN data can be structured and exchanged. The current federal certification baseline, US CDI version 3, includes standardized demographic elements. This includes race, ethnicity and tribal affiliation, sex, sexual orientation, gender identity, preferred language, and disability status. And it also includes certain categories of social determinants of health, specifically those related to assessments, problems or health concerns, goals, and interventions. But again, standardizing elements does not mean organizations are required to collect every element. So we'll keep that in mind as we start to produce recommendations, and start to as we consider these recommendations, we might consider how a standardization and structure of this data is necessary to produce exchangeable data. We'll go to the next slide. We do want to acknowledge that the federal standards environment continues to evolve. Today, US CDI version 3 is the required federal certification baseline that we as the DxF reference, and that does include sexual orientation and gender identity data. But at the federal level, some proposed changes, including those shown on the slide in HTI 5, could revise that baseline. This revision includes changes to certain sex, sexual orientation, and gender identity elements. Separately, the standards version advancement process, or SVAP, starts to allow certified health IT professionals to use newer versions voluntarily that might not include the elements in version 3. And as we start to create recommendations, we might consider how we continue to remain workable under an evolving federal landscape. We don't have to answer that question today, fortunately. We're just looking at the current landscape of things. Let's jump to the next slide. So here is our path to recommendations. Today, we're hearing on-the-ground perspectives. As I mentioned, in October, we're diving directly into potential recommendations. So we would look for you to surface the priorities and opportunities from today in October. And then in December, we will refine those recommendations and formally vote on them before we meet our January deadline. So as you listen to the presentations today, keep an eye out for potential solutions in October. And with that framing, let's go to the next slide. I have the privilege of turning it over to our first guest speakers, Carrie Sanders, the Senior Policy Director, and Ignatius Bao, the Health Equity and Policy Consultant with the California Pan-Ethnic Health Network to continue the look at our current state landscape. Carrie and Ignatius, I'll turn it over to you.
Great, thank you so much. Carrie Sanders here. Good morning, everyone. Senior Policy Director with the California Pan-Ethnic Health Network. Hope you all can hear me. Happy to be here today to talk about health-related social needs and demographic data collection in the exchange. Next slide. Can you all hear me? Oh, great. So for today's agenda, we'll be sharing a little about several common themes that were elevated during a series of key informant interviews that CPEN and consultant Ignatius Bao held together in June and July of this year. Next slide. But first, just a little bit about CPEN. We are a statewide health advocacy organization dedicated to bringing together and mobilizing communities of color to advocate for public policies that advance health equity and improve health outcomes in our communities. And we do this through policy advocacy, network building, policy research, and storytelling. Next slide. And you can skip to the next one. So I know Michael already went over the SB 660 statute. Just have it here again for all of you. But we'll be providing a little bit of information around our findings this seemed like a good moment to take stock of where we are. Next slide. And so why are we collecting this data? We know it's well documented that there is persistent evidence of health inequities based on demographics and health-related social needs. No single provider, systems, or sector can eliminate those inequities by themselves, which is why this data is so important, and the exchange of this data really to allow all providers, systems, and sectors to see the clinical and social needs of each person and work together to address them. Next slide. So again, as we're nearing the January 1st, 2027 deadline, this seemed like an important moment to, again, take stock, assess, where are we and where are providers today in collecting and reporting this data. So in June and July, CPEN and our consultant Ignatius Bao, who's also here today, conducted key informant interviews with individuals from public and private insurers, purchasers, health plans, hospital associations, clinics and physician practices, community-based health and social service organizations. This was not a comprehensive or representative survey of the healthcare sector, but we noticed commonality in several themes, which we will uplift today. Next slide. And so as we think about demographic data collection, most importantly, all of the interviewees we spoke with are committed to health data exchange to improve quality and advance equity. All are committed to collecting, sharing, and using demographic data for these important purposes. As we, look specifically, we see race and ethnicity data is the most complete data, followed by language data, and all understand the importance of collecting, sharing, and using data about health-related social needs. Next slide. Turning to the collection of SOGI data, most have begun to collect this data on sexual orientation and gender identity, but the data is far from complete. Many expressed concerns, particularly in the current political context, about continuing to collect and use sexual orientation and gender identity data. If you are collecting disability data, some are just beginning to explore disability data collection. Next slide. There were also broader themes that were elevated. Almost all interviewees referenced expected organizational resource constraints, especially from implementation of HR1, with decreased Medi-Cal enrollments, payments, and increased uncompensated care. Many have concerns about privacy, mitigating organizational risks, and shielding data from federal inquiries and investigations, especially gender identity data. And many are hearing privacy concerns from patients, members, and community members about immigration enforcement and trans healthcare. With AI, others have concerns about who owns and uses their own data. Next slide. Our conversations also raised some operational issues and potential opportunities for TA as well. For example, there appears to be inconsistent knowledge about data exchange and its potential use cases. So perhaps, additional use cases could be helpful. Data exchange is often unidirectional. For example, folks using it are receiving admissions discharge data or health-related social needs data from hospitals. Small physician practices are generally not using data exchange in a meaningful way. And so this is another area of potential technical assistance or focus. And then finally, social service organizations who are, providing assistance and following up on referrals, for example, through CalAIM, are generally not using data exchange. But they're reporting information perhaps into systems, but they're not utilizing the exchange. But they are working on closed loop referral systems to be able to follow up with patients or individuals that they are working with to close that loop. And with that, I think that's it for our presentation, I'll turn it back to HCI and other presenters. Thanks.
Thank you so much, Carrie, for providing that perspective. Before we move on to our next, we can go to the next slide. Before we move on to our next presenters, we just wanted to provide one additional data point that we might consider. We shared in your pre-reads some information from our hospital equity measures work, which describes the collection and reporting of certain health-related or social determinants of health, rather, and demographic data. And you see some successes in certain industries, like with acute care hospitals, and some challenges with others, like acute psych hospitals. Today, we just wanted to provide one other data source, and that is the American Board of Family Medicine Continuous Certification Questionnaire. This questionnaire started to ask family physicians how often they document screenings for social needs, such as transportation, housing, food insecurity. And really, the bottom line here, almost 1,200 folks answered this survey. And of those, about 56% report that they often or sometimes are documenting it, but they're doing it in a narrative clinical note. About 35% of them are entering it into specific diagnoses codes, and only about 25% are actually entering that information into discrete fields in their EHR. So this is one illustrative, certainly not comprehensive source and picture of all DxF participants, but it does highlight an important issue we might consider as we start to think of best practices, and that is really about how might we start to standardize and move towards exchangeable data. With that, we can go to the next slide. I'm going to turn it over to our next external presenters, Elena and Cami. Thank you guys so much for joining us, and I'll turn it over to you.
Thank you. Good morning. Thank you, HCI and the committee, for this invitation. My name is Cami Christensen. I'm the Chief Business Development Officer at 201 San Diego and the Community Information Exchange, or CIE. I am here to share a little bit about the San Diego story. We launched our CIE in 2014, so over a decade ago. We've been doing this local data sharing, and it organically grew from meeting the needs of what we saw in San Diego. We'll provide a brief overview of our data sharing model and coining the term Community Information Exchange, or CIE. CIE exists for the sole purpose of coordinating care for individuals. So we talk about data sharing, we talk about consents. Folks are consenting in to share their information purely for the individual coordination of their care. If you want to go to the next slide, we started this work in response to community needs. All of our community partners were willing and eager to join our effort because the value for sharing the data was understood. The value for CIE is the coordination of care across multidisciplinary organizations and across different sectors. Holistic care is inclusive of social services, not as an afterthought, but because of social services, public benefits, access, healthcare, education, and employment. The San Diego providers recognize the need to close the loop on referrals, like we just heard, but also having access to a single longitudinal client record across multiple different organizations and sectors, so that the folks that we are all serving don't have to repeat their basic facts, their demographic information, their household size, their income, and their current situations, often having to recount their traumas to validate their eligibility for basic programs. Here you can see the definition of a community information exchange. We are not a QHIO, but in San Diego, 201 San Diego also oversees our San Diego Health Connect, the QHIO. CIE is an opt-in model with numerous different care planning tools, including screening and assessment tools, closed loop referral engine, an program eligibility engine, and most importantly, an aggregated individual client record that brings in data from diverse data systems that populates a single client record. If you go to the next slide, you'll see the core pillars of what a CIE is. It is the multidisciplinary partners across the ecosystem. We all have a shared language of our contracting terms. So all of our partners, whether you are a small two-person faith-based organization or a large healthcare system, all have the same contracting terms. Folks can use the same social determinants of health assessment tools, same language on the referral dispositions and program outcomes. So CIE allows programs across different sectors to share in individual client outcomes for their kind of program efficacy. San Diego CIE is grounded in local governance. So we've been doing this work as a CBO for over a decade, and we acknowledge and very clearly communicate to all of our partners about data ownership. The people who we serve own their data, and they decide when to share their data by choosing to authorize the release of their information. CIE is an opt-in model. The CIE network is a diverse network of HIPAA-covered entities and non-HIPAA-covered entities. Today, the CIE record is shared using variable and very detailed role-based permissions to about 1,300 licensed users across 141 different organizations. Those licensed users can log on directly to our web-based platform. Over the years, we've built about 18 different data integrations with our partners' source systems, including a Epic integration with our local large hospital system, several FQHCs, EHRs, several housing providers, CRMs or source systems, as well as local managed care plans and commercial payers source systems. HMIS, or Homeless Management Information System, was our first data integration almost 10 years ago. Connection to the HMIS system in partnership with our local COC and local HMIS provider, Regional Task Force on Homelessness, has transformed our community's ability to serve our community's most vulnerable unhoused populations. Most recently, that HMIS integration alongside our shared housing assessment has shaped CalAIM Access. Because we have in San Diego the integration with HMIS, we have hundreds of users logging into CIE to document eligibility for the 3 housing suite of community supports. So folks can log in, screenshot the history of homelessness, attach that to a referral to the local managed care plans, and they can expedite their authorization to receive community supports, especially the 3 housing community supports. We're working really hard to replicate that use case in response to HR1. I was delighted to hear a few references to HR1 impacts already today. In our community, we already collect Medi-Cal renewal dates. However, to validate the Medi-Cal renewal dates shouldn't be as hard as it currently is. We have a CIE community network who stand ready to help our San Diego providers and our clients understand what the new steps that are needed to maintain their public benefits and the changing recertification rules and work requirements. And that Medicaid renewal date is kind of the way that we can prioritize reaching out and getting them connected to the needed resources and care. Next slide, please. Each of our CIE partners use CIE in different ways to coordinate care. Some look up client demographics and program enrollments or a history of homelessness like I shared, or to identify who else is working with their client or the family that they're serving. Some partners, like large hospital systems, push referrals to other partners outside their network, like enhanced care managers, community support providers, or housing providers, and those folks receive those referrals. Many users use our social determinants of health screeners and assessments to identify needs and filter the 201 resource database to locate the most appropriate resource and push that closed loop referral. Care team members in CIE also receive alerts similar to a QHIO or an HIE's ADTs. In CIE, it can be a status change alert, such as a release from jail, a Medi-Cal renewal date like I referenced, going out to all care team members, or an alert about a return to status of homelessness or an exit of homelessness to permanent housing. Those alert functions are really what changes the care from a reactive model to a proactive model. So instead of waiting for folks who are in crisis to reach out to the system of care, we use data and the alerts to inform the care providers about status changes, to do something different or to engage earlier in the process. If you go to the next slide, it feels like this is preaching to the choir a little bit, but why are CIEs critical and what are we trying to solve? We do this work because breaking down the data silos across sectors aids in the provision of whole person care to help the direct service providers, including social and healthcare providers, provide more trauma-informed care. And finally, by having a unified cross-sector data system, communities can use that data to better address long-standing systemic barriers, inequities, and gaps in care. Over the years, we've seen a lot of data sharing models fail because they were not grounded in community and didn't leverage existing infrastructures and the infrastructures of existing service providers, as well as their existing technologies. Key to this work is interoperability, and I will turn it over to my colleague, Elena Kalinowski, to introduce herself and her local and national work.
Thank you, Cami. Hi, everyone. Elena Kalinowski. Really grateful to be here and always very excited to talk about this work because, like Cami, I think it's very important for the people that we serve. I'll just give a brief context. I am a social worker like Cami as well and have been in the nonprofit sector for 20 years. And I get to work with the Gravity Project. I sit on the steering and operational committees alongside terminology and tech implementation work groups. And then I also get to work with the state of Washington, building up a statewide CIA with the Healthcare Authority and Comagine Health. So it's been a really great experience getting to think about how CIE activities get to take place and interoperability gets to take place in different contexts. So I'm going to, if we can go to the next slide, please. I'm going to just very briefly kind of tuck into what Cami was just describing. Really, the network and the activities of the care coordination are powered by the interoperability and the technology, right? It is not the driving feature, it is what underpins it. And so in our local CIE, we do have a really an ecosystem that reflects the interoperability that are the needs of our service providers. So we do have the ability to have bidirectional data sharing, but it's very much driven by utilization and needs. So we all know that data sharing is not just data sharing for data sharing's sake, right? It is grounded in like, what are we trying to do here? We're trying to either help someone understand what their situation is. We're trying to understand where they're already coming from, what's worked, build on what other workers have already been doing, understand people's priorities and preferences, and really support that self-determination and agency of that person who's already managing a whole host of situations. But then also we are trying to take some of that burden off of people in that care coordination and say, hey, how can I, as a service provider, leverage technology to connect someone directly to what is also out there? And so whether that is, and actually, can we go through the next slide? Through closed loop referrals, that might be through shared assessments, that might be understanding that someone's already enrolled in a program and how can I help them get connected to another program that supports this work. So what we have here is kind of over the years, the interoperability of our system has essentially driven different types of utilization that relies on different types of data sharing, right? So it's maybe I want to use CIE functionality. Maybe I want to use it within my system. Maybe I want to augment my system by using CIE and just allow for data sharing to make it so I'm not doing dual data entry, right? There's a whole host of reasons why we need to be able to connect to different types of service providers as well as data sources. And I think that the understanding like what is needed to understand someone's situation so that I can effectively support them varies. By, Cami noted, there's so many different types of service providers that are all a part of this ecosystem and serving in different capacities. And so being able to not just have a longitudinal record that just has a lot of information, it does need to be informing what comes next. And so that's really where, when we think about the interoperability, it is so that organizations and service providers can do better work, right? And so if we can go to the next slide. This is actually, Cami kind of already noted this, so I'll kind of breeze past, but we've been able to connect to a lot of different types of systems. with a lot of different types of data. And some of that is to leverage interoperability to kind of use functions of CIE and care coordination. And sometimes it is being able to populate the longitudinal record with really meaningful data that informs everybody else's care coordination, like the HMIS program enrollments, for instance. And so I think the utilization of CIE infrastructure takes different shapes, but it also, it's because care coordination, and if we go to actually the next slide, is both the intersection of understanding what someone is looking for, what they need. Can we go one further? And perfect, thank you. And some of this data has already come up in previous presentations. But it's both understanding what is it that someone needs, and that's how do we find interventions that meet that need, and how do we identify specific service providers that are able to not only meet that need, but to meet the need of that specific person. And that's part of where care coordination becomes so difficult and nuanced, because what is true about someone, their demographics, their situation is contextual. It is situationally based, and it's relevant contextually as well. So as a service provider, I am typically, my program eligibility is based on typically my funding source, right? And that is, I have funding carved out to serve specific people. So that might be based on zip code, age, other demographics. That might be based on specific diagnoses. And the variety of what needs to be known is quite broad. And that's where I think we often are in these conversations, really getting into the meat of, well, then what must be known in order to do effective care coordination? And this is where I think if we can go to the next slide, there's examples of, like in San Diego, we've had the opportunity to bring together CalAIM contracted service providers, local government, our CIE, payers, or MCOs, and really think about, like, okay, if we are trying to do, say, for instance, CalAIM care coordination, understanding where is someone enrolled, who are they getting, supports from, and how do we help get people connected to the supports either they are already connected to when they need to be, or identify and get people connected to services if they're not already, for CalAIM. And so like the work being done of identifying, like, okay, well then what is the data that we need to share in order to be able to do that? That work gets to happen, but it's difficult. And there's a lot of consensus building activity that goes alongside that. And being able to stay grounded in, like, what are we trying to achieve, and not just have data sharing for data sharing's sake again, but also think about, like, what is the context for protections and really client agency in what gets shared when and how. And so that, if we can go to the next slide, I think this is actually where we have some of the recommendations from our experience, right? So part of it is line of sight for care coordination is one of the main pillars and reasons why CIE exists, right? Being able to know what's already happening and build from it, especially with things like Medi-Cal enrollment in and of itself is wildly important, from not just from a CalAIM perspective, but that's really true for a lot of eligibility and care coordination. Just knowing that someone has, a 138 FPL because they have Medi-Cal is already often a categorical eligibility just baked into someone's intake. So those kinds of things, knowing someone has enrollment, being able to understand what plan they have. Are they already enrolled in supports? Are they already enrolled in ECM? These kinds of things, like, make it so we're not duplicating and starting over again. And so, I will say in the work that we've done around interoperability, being able to connect to our San Diego specific MCPs has been really meaningful in providing some of that data. But those are essentially like one-off integrations, and being able to, say, have that data directly from the state would be, like, very meaningful from a connection lens. Data that really everybody needs, like Medi-Cal enrollment in particular, but not just Medi-Cal, it's other state benefits, because those benefits are so critical and crucial to people's stability, and being able to, make sure those are already covered. before we get to also do other, more intense care coordination is such a building block. So I think the other piece of this is yes, we know why we are sharing information and how do we address the very valid concerns and need for consent. And one of the things that I think has been coming up a lot in the work we get to do is there's a lot of frameworks for data sharing, basically going from a HIPAA covered entity to a non-covered entity. But social data is often very sensitive and vulnerable as well. And it being both collected and shared, even within covered spaces, there's not a lot of frameworks for need to know. And really it being driven by care coordination specific need to know. So I might want to really only have specific information of my social needs or just demographics shared about me because I'm trying to access a specific service. So maybe it is, I'm seeking this specific program that requires really sensitive information. And that might be health related and that might be more social specific. But being able to have frameworks for need to know basis, whether that's healthcare or social care services, data is really, I think, one of the missing pieces for how we think about protections and consent, and really models that help balance the needs of both when we need to share data and also limit it as well. Sorry, I'm like covering my camera here. And then there's other components to that. But then one of the other last pieces I'll just touch on is being able to also support minimal data sets, recognizing that just sharing contact information often puts an administrative burden on social care service providers receiving referrals that also without enough information is quite a bit of cost, and not only for a person's experience trying to get connected to services, especially if they can't get enrolled or are not eligible, but then also the receiving service providers have to bear quite a bit of care coordination weight. So those would be some of the things that I think we've really covered. Is there anything else?
No, I think I'll just close with, you've heard kind of our story from San Diego over the last 12 plus years. And I think knowing what we want to accomplish as a state, and we work a lot with other communities and other counties throughout the state. And I think to expedite and enhance the data sharing, we need to figure out how to streamline it and make it easier, because not every county has the support that we have from our county. Not every county has a deep relationships with our service providers and our managed care plans. And so I think that we're excited about this work and we're eager to kind of roll up our sleeves and join you.
Thank you so much to you both. Really, really great hearing about the work you guys are doing. We have one more external presenter for us today. We can go to the next slide. We have the pleasure of introducing here Dr. Brian Thomas, who is the director of the Social Health Information Exchange with Alameda County Health, to add another on-the-ground perspective. Brian, I will turn it over to you.
Hello, everyone. Thanks for having me today. I'm trying to switch to the presentation, but it looks like screen's changed a little bit. Okay. There we go. Okay. So in addition to making you all a little hungry before lunch, we decided that we wanted to come up with somewhat of a clever metaphor for the DxF, in that everyone knows what it is. So everyone knows what a Big Mac is. It's not a lot of ambiguity. It's a very interesting thing to us in that when you know what it is, it doesn't always mean you know what you can do with it and you know what it really consists of. And so we wanted to sort of stretch that a little bit and talk about the DxF that way. Wanted to be sure, thank you. Wanted to be sure that we just understood some basic pieces in that it's a compliance foundation, and that we're looking at health relating social needs data, and that it gives us a compliance foundation. I think those things are pretty well known, pretty well understood, And oftentimes when we talk about it inside of our agency, we sort of go back to that beginning of that to sort of talk through those things. But we realize that the way to facilitate this is not so much to talk about sort of those foundational things all the time, is to really talk about, well, what can you do with it? What is it that it helps with? And how do we facilitate outcomes that we want within our respective program areas? And so we started to sort of look at it a little bit differently, as opposed to going always back to sort of these layers. Next slide. So one of the things that we wanted to promote as we sort of have the framework in place and it starts to proliferate across the state is to really point out that in certain situations that we haven't always thought of, it gives us a look and view across the state in terms of things that we could do that we didn't always do before. And one of the questions that came to me was from our housing group. They really wanted to understand what are services that are being provided for housing for their particular members across the state, because it helps with planning and it helps them to understand sort of things like migration patterns and patterns of activities in terms of services that are being provided outside of our county and what might be provided someplace else, and would we be able to see that information and data? And the reality is that as this sort of framework proliferates, we will be able to see those things and we'll be able to plan better and we'll be able to coordinate services better. And so it does give us a lot of hope and opportunity to utilize this in ways that might be less than traditional. Mostly we look at these things in terms of coordinating just services, but not necessarily always planning for services or understanding the patterns of services that are being delivered. So that was sort of one of the things that we found to be a good opportunity. And so we wanted to talk about it a little bit from that perspective. Next slide. So this is what we're building, and this is the type of data that would be available to be able to see that activity that I was just discussing. But when we look at sort of the infrastructure data relative to housing, these are things that we didn't always sort of look at in the same way, and we just want to be sure that we're giving all of our programs an opportunity to have a look and view into the data that we would have. So that it can help them sort of mobilize services and strengthen the care coordination effort. Having data that is part of an integration model within our county health agency is something that I think that is sort of new in terms of realizing its strategic opportunity. And so we wanted to be sure that we were pointing that out. And then the standards and adoption, I think, is just a really important piece, because the design methodologies have to take into consideration the program leadership opportunities. And we have to sort of collect what do our program leaders want to do with that, and how is it helpful to their respective areas. And so we wanted to be sure that we were doing that and giving them some feedback as to how that is happening and what those connection endpoints are. Next slide. And I think what was talked about earlier that's so powerful here is that it sort of helps us obviously mobilize the consent framework and its complex sort of nature. The conversation that's transpired within our agency has allowed us to really talk to our entire group about how do we get prepared for consent, and how do we sort of whittle down the many consent forms and documents that we've had in the past, and then how do we sort of conform and comply with the ASME framework. So those conversations are taking place, but it's really showing and demonstrating that the standards are helping us collect ourselves around that effort. Next slide. So by having these conversations and sort of opening up these topics of conversation in terms of what are the benefits of sort of the DxF framework, is we sort of start to look at the silos and behavior patterns of each of our programs. And so bringing them into sort of that standardization framework and having something like the SHE be a model to sort of adopt this new framework has helped us considerably not only have the conversation, but really sort of be able to demonstrate the benefits and really sort of test the different structures that we can put in place, as opposed to trying to work within every silo and utilize system structure from each silo. We've sort of said, hey, we have data that we can mobilize from those structures into a comprehensive data sharing framework and inside the sheet, and then we can sort of develop around that. And so that's what we're doing. And what it's really helped with is really understanding where data is not only coming from in terms of our different data partners, but it's really revealed that maybe sometimes we have overlapping data coming from the same source, but into different parts of these different silos. So we can help to sort of manage that better and improve that activity. Next slide. And in terms of the consent framework and how that would work, what we've really talked a lot about is sort of the query response capability and sort of the gaps that are associated with that. And so one of the concerns has been is what will be the pattern of activity in terms of consent. And so what we've tried to do is sort of model that behavior around the consent framework that we've had in the sheet for quite some time, and really talk about what should you expect to get back and in the query response methodology for consent, and what would be the turnaround. And so we've really sort of talked through with the different leaders in our agency, so that they can understand that sort of the scale of this is sort of starting at relatively small today and sort of growing out from there. But there are some barriers to doing that, and one of those we'll look at a little bit later is just sort of the speed and timing of this. The response time is going to be critically, it's probably right now a bit of a gap, and it's hard to talk about in terms of what that gap would be. Next slide. And so this is sort of an area of opportunity where we're sort of saying this is what our vision is and what it looks like and sort of what we're putting in place, recognizing that there are some gaps and recognizing that the real-time DxF framework is really what's going to allow us to achieve what I think we all want to, which is to be able to query the information that's available from county to county and get back a response in a real-time fashion, and be able to utilize that data to equip our partners and our program leaders across the agency. And I think once we start to see that come into focus, the benefit that I was talking about earlier really starts to show itself. And so we want to sort of promote those benefits as we sort of talk about it. And we really want to make sure that the standardization of the program is really something we can all adhere to, because that sort of enables that real-time turnaround, the more standardized we are. I think that's the last slide. Any questions or?
Great. Thanks so much to all of our speakers. I think we're going to take a moment and open up to the committee before we jump into some prepared questions. Just questions that you might have for the speakers or the topics that were brought up. And I was going to ask one, but I'm gonna take my agency as chair and go first, if that's okay. And then I will call on you, Julie. So I had a question. I think it's been super helpful to hear the use cases, the rationale, the why of all of it. And I actually think there's a lot of alignment amongst at least the committee members in this room, and I think in many parts of the healthcare ecosystem, about why this information is important and what it can enable, and also understanding that everything isn't for everyone and there has to be some structure around that. I think my question, and I feel like it's maybe most first of all for San Diego, and then maybe second of all for Lynette, but like when you get into the nitty gritty of like the hundreds of organizations, we've got gazillions of EHRs, some are written notes, some like we looked at the, American Family of Family Physicians, right? Like this could be documented in a SOAP note, it could be documented in Z code, it could be documented in a standard form, and that's just an EHR. And then you get into community organizations that may have no system or have different systems. And so I'm sort of curious, like how you pull together that. I mean, it's nice to say we have standards, but like, how do you actually get that to happen? And like, what does that look like? And what are those sort of key things that need to happen and the barriers that you're overcoming? Because I sort of feel like if you have a some movement and interest in making it happen, but then like, the worst thing is you try to make something happen and then you don't have what you need, and then it just nobody believes it, right? So I'm curious how that went for you all and what that journey is like. What we should be thinking about.
Yeah, thank you. I think so one of the things I'll just note is from the integrations and data interoperability in general, CBOs tend to have, if they have a system in general, they tend to be a little bit more flexible in how they're interoperable. The data gets to be what's able to be shared and what they are able to receive from our CIE. Their APIs are usually a little bit more configurable. And there is essentially usually more textured data that gets to be shared. So I say that because I think there's sometimes a bit of a mythology around what CBOs are able to share and be in terms of an interoperable perspective. That's not to say like a food pantry has the same system, but if you think of like a multi-service system, they're highly sophisticated with many braided funding streams that require lots of reporting and analysis. So they've always been they were our first kind of test cases and drivers in data sharing for the purposes of like different types of care coordination. So that might be, I want to be able to take advantage of closed loop referral functionality within CIE, and I want to be able to have my client record populate. I want to bring over my program enrollments, things like that, and I want to be able to pull back referral outcomes, like those kinds of things. So that's like, I think from a social service perspective, that's been really important for us because it's really helped us understand what's key for workflow and key for care coordination, especially within like that multi-sector lens, who are case managers who are trying to address all these different types of social needs.
I guess I'm like trying to drill down a level below that. So that to me is sort of still the use case. Like okay, so I'm a practicing primary care physician. If I want to understand that the patient sitting in front of me is homeless and I need to work actively now, and that I need to work on that, and I could have some pre-information to prep my team or bring my case manager on board to do that. Like there's an element of like, where's that information coming from? Is it a standard, like in what format? And like, how does that get from you to me in a time frame that it's not like this patient was homeless a year ago.
Yeah,
they're homeless now. Like, so, and I don't want to get into HMI. Like, I'm just trying to, like, I use that as an example. It could be food, it could be whatever, but I'm just like, how do you, because it seems like you have to have some structure that every person cooperates with, and like, what is that, and how do you get people to do that?
Well, and I also think this is like, as a CIE, part of our role is we translate a lot of data. And we map a lot of data using both standards and non-standard data. So that's like a big component, right? And so that might be, say we're taking something from a FHIR API, we're using that type of data standard, and we might be mapping it to other things. So there is quite a bit of translation that takes place in a CIE between the different sectors. And to your point, like, there's not necessarily the same type of structured data within social care spaces, right? It's a lot of unstructured data. Yeah. But the things that tend to be the most like essential, like, are you currently homeless? What's your chronicity? Those kinds of things, like in that moment, that tends to be structured data. So I think that's where for us, it like things like SOAP notes don't really actually come up in the way of like critical information across these different sectors. And that's not to say there's no use case for it. It's just that tends not to be as actionable in the same way.
Okay. So you kind of put out like a set of, here's how, like you're mostly taking and aggregating, and a lot of your work is like sort of normalizing.
Yeah. Well, and then when we share data out, it's also able to be like essentially mapped back or back to someone else's system.
Okay. That's helpful. And then I don't know, Lynn, I was thinking about Medi-Cal Connect, and I was sort of like as one, and I was thinking about some of the requests around, so with the state part of this data, but I also would love to hear, it'd be great to hear from you all as somebody who's done a lot of looking at this across our state, what you see as sort of current state challenges, opportunities, what we should be thinking about.
Yeah. So as the team has been talking about, right, there's lots of details in terms of how it works. And actually, I always love hearing you explain what's going on the ground, because you're closer to it than we are. That being said, this is where we've been working through a lot of our policy initiatives. So CalAIM, the various population health management programs, trying to really drive this kind of connection and the policy need for why data exchange matters, and why data exchange for health-related social needs matters, because we're trying to put the patient at the center and have that holistic view in terms of providing services to them. So there's a lot of work in that space. You asked about Medi-Cal Connect. So Medi-Cal Connect, for those that aren't familiar, is a population health management tool, essentially, that we have at the Department of Healthcare Services. And we have made access available to our business associates, the managed care plans, and county behavioral health plans. And in that context, we've brought together the data that we have from Medi-Cal, but we've also set up agreements with other groups to be able to bring in data like the Homeless Data Information System, immunizations from CDPH, vital records data, foster care information. So there's a lot of information that we have been able to bring together in that view. And in that context, there's two primary uses related to the Medi-Cal Connect environment. One is really that population health management perspective. So looking at various quality measures, utilization measures, outcome measures across all the different stratifications, plans, counties, ages, demographics, et cetera, that then can be used to drive quality improvement, focus resources, either by us, by our plans, by our counties. But then there's also a component that does have a view that is a longitudinal medical record from the context of a care manager that's at a plan or a county could then log in and get that more complete view. And so some of that is included adding particular flags to, for example, indicating that somebody has a significant behavioral health need. And there's a variety of things that could cause that to be a positive flag. So those are things that we've been building over the past several years and have been rolling out increased functionality. In particular, this year in the context of behavioral health transformation and Prop 1 and those efforts there in the behavioral health space, we've really been expanding some of those pieces in terms of measures and content. But one of the things that everybody always asks is Medi-Cal Connect and HIE. It is not an HIE, just to be clear. From day one, 5 years ago, it is still not an HIE. The Medi-Cal Connect really is a population health management platform to bring together a particular view to understand the patients and the members that we're serving from that perspective. One of the things from a longer term perspective is how do we understand additional aspects. So when we start talking about data exchange and information that could be coming from QHIOs, what's that next step of SNOMED, LOINC, not just claims data that we paid for a test, but what were the actual results of the test? How do we start to understand that, start to bring in notifications, event notifications? So we see a huge opportunity to enrich that population health management view with the data that would come from the more clinical side of the house in terms of information that starts in an EHR and how that feeds in, as opposed to what we have now, which is all of the claims data. So standard HIPAA 837 transactions, et cetera, is really the backbone of the population health management service, which is Medi-Cal Connect.
Yeah, that's helpful. Thank you for that explanation. I am curious, since we're talking about QHIOs a lot. I mean, there is data in Medi-Cal Connect from particularly other state agencies and partners that really isn't easy to, like, in one place for a Medi-Cal population necessarily access. And so I am curious, like, on the roadmap, QHIO connectivity for Medi-Cal Connect, like, what is that?
So it's not so much about QHIO connectivity per se, because the driver, so we have spent the last few years developing all of the data sharing agreements to bring together these pieces. And the context of the essentially additional sharing is through our business associates with our counties and our behavioral health counties and our managed care plans. So everything in there is governed under those business associate agreements. So it's not that we could say line up with QHIOs and then share that out further. All of the data that's come from outside of DHCS is based on very specific data sharing agreements and requirements in terms of any other additional sharing we can or cannot do with that. So that gets into some of those aspects, but there's definitely a whole raft of things that we would very much like to connect to QHIOs to do, both in terms of receiving data in and potentially sending data out. So those are all things that we're working on and thinking about.
Yeah, I mean, I hear in all of these presentations sort of interest and opportunity for state
Mhm.
information. And you guys have spent 5 years putting together that system. And so I don't know, there's a little bit of a push to not like that, like a one-sided system, right? And like, how does that come back and connect in the roadmap once you guys have it where you want it? So that's super helpful to hear about. Thank you. All right, we're going to go to Julie.
Thank you. Yeah, I think I'm going to tie in what you just said. So one of the things I want us to, as a community here, is think about is where we are with SB 660 versus where we are in reality right now. And I think San Diego did a really good job of talking about we're kind of in a crucial moment around HR1 and the really important aspect of being able to have Medi-Cal renewal dates available to social determinant health organizations, health organizations across the state, because we're about to lose millions of people are about to lose health coverage. And this conversation about sharing data will be irrelevant if they're not covered. And so I want us to think about in that goals of demographic HRSN, like prioritize or add into what, like, as you said, I think your question was how can we articulate the goals better is to get that piece of care coordination in there. It's like making sure those of us who touch people who will not be seen anywhere by anyone else but me to know that they're about to lose coverage. And so having the system where people there, I'm really going to urge the state, like if the state could find a way to share out data with certain sectors, like there's 4 HMIS vendors in the state. If all those HMIS vendors got Medi-Cal data, then all the COCs, all the homeless systems of care would have them and they would have an alert. And so anytime I went in to touch the system on behalf of my client, I would get the alert that said, Kieran, this month is up for renewal. And right now we're looking at it at a very local level with the managed care plan, each managed care plan with each COC, but it would be really great. And I just think I want to help make sure that that is like paramount in terms of our mission is to figure out how we can enable that. It didn't exist when SB 660 was written. We didn't have to worry about that. It wasn't our reality. And a piece of that isn't just the renewal dates, but people have to be excluded based on their disability status and functional limitations. And this gets back to, I think, what you were talking about, Jennifer, is a lot of the data isn't going to be available in our regular systems. It's about functional limitations suddenly, and all, it might be in your notes. I don't know where y'all save that stuff. If there's a few Z codes that have it in there, but most don't. And so suddenly now the role and the importance to keep people covered of whatever you all are documenting is, I think, really important. So I just wanted to say like this, making sure this is on our radar for October and December as a priority, or at least as equal priority as all the other things. And then I also wanted to just speak to something that Alina said on need to know. Thank you, San Diego folks, for bringing our voice back in here more, is the need to know. A good example on when we think about QHOs or any kind of data sharing is like an example of it is people experiencing homelessness live at particular encampments and they don't want law enforcement or ICE to know where they are. And that's a really good example of need to know. And there's probably millions of layers, but we have been really strong in the homeless systems of care, not allowing law enforcement into the databases for these primary reasons. And I think we're getting more and more where that's going to become more and more important across all social service systems. So just wanted to give that as an example of like really blatant need to know issues. So thank you for letting me talk so long.
Thanks so much, Julie. Appreciate it. We have Mark on the line. Mark, are you still there?
I am still here. Thank you. Thanks so much for all 3 of the presentations. Really, really great. I wanted to especially lift up in the 2-on-1's presentation, slides 48 and 51, which sort of try to capture in a matrix level some of the granularity that goes back to your question, Jennifer, about drilling down. What's this like for the diversity of users on the ground? And I thought I'd share a little bit of work that I did back with the Office of the National Coordinator in 2024 around health equity by design, where we sent out a draft paper for comment and we got comments back from a range of users across the nation. And I thought some of the themes might add some of the granularity that you were asking about, Jennifer. So Theme of data. There were people who said too much data, too little data, not all the right data. They need more aggregated data. They need more granular data. They need data maximization, meaning, which is sort of, a lot of data minimization. We can't drink from the fire hose. Raise data quality and integrity issues. Just, a range of things around data and different perspectives depending upon what they were trying to do with it. If they're on the ground trying to provide as a social services organization or a community-based organization trying to provide care for an individual that's in front of them, they may not need the entire system of data. Another major theme was those who are working with federal certified EHRs and those who weren't. And I know it's a it's a broader diversity than just those two big buckets, but are you using a CERT system, CEHRT, or are you using a non-CERT system? Are you covered under, third theme was, does HIPAA cover you? Does it not cover you? That's come up before. We may see some help coming out from OCR in the next month or so with a new regulation, but it creates a lot of friction for knowing how users on the ground can and can't provide and work with the information that they do have. So those are just three different kinds of examples. I think the slides 48 and 51 capture that in a different way. So I'm just adding my own experience there in case that's helpful in this level setting that we're trying to do today. Thanks.
Thanks, Mark. That is very helpful. Appreciate that clarification in more detail. Aaron, let's go to you.
Hi, I just wanted to second Julie's comments around renewal dates and getting a high quality data set for renewal dates. This is a high priority topic of conversation from all of our clients. All of them, the health centers are working with vendors or working themselves on outreach efforts. And the quality of the renewal dates that we have access to through the payers varies greatly. And getting a high quality data set would be extremely helpful. That the health centers all want to help on this effort and they're struggling.
Thanks for sharing that. Yvonne.
I feel like all of us sitting on this slide are all kind of thinking the same thing. So one of the things that has come up, and I agree, I think that there is a urgent need right now. I mean, I know that we want to get a perfect system, long term, but I agree that I think renewal dates, I mean, right now, I'll just give an example. As we are hurtling towards the effective dates for HR1, things that have come up, and we want our providers to be able to be proactive, right? We don't want them to wait till January 1 to start figuring out who's impacted. And it has been like we've been talking amongst ourselves of even trying to identify who are the potential universe of impacted beneficiaries so they can at least start getting their records together, even if it's not exactly, but the broader universe of who might be affected. And I'll use an example. Yesterday, DxF sent out I don't know if it was yesterday, I got it yesterday, information about what are we going to do about the UIS population, right? And how our notification is going to happen. And it was making my palms sweat a little bit because it seemed like the deadlines were very short, right? And DHCS was like, we're going to send a letter once in December, and that's going to be it. And then plans, it's going to be on you to figure out. And there was no real discussion about what struck me is it was all still very much a paper-based system, right? Or email-based system. There was no like, hey, remember if you're connected to this, you could be, I felt like I think we need a little bit more vision from the state as we are having these conversations around data sharing. Let's put some of that into action. You don't need a bill to tell you that you can tell the plans, hey, if you're sharing data with others, these are things that you can be doing, but the instruction that we're still seeing from the state feels a little bit dated, right? It's still postcards and letters, which is great. Like we want to meet people where they are, But if they have the capacity, I think the state needs to sort of start that conversation with plans to say, hey, think more broadly about ways that you can let people, like, if our ultimate goal is to figure out how do we identify those beneficiaries at risk as soon as possible, what are things that we can be doing kind of in that data sharing space, and that is within our existing authority. Like, let's do that. Let's make those UIS identifiers available. Let's make those renewal dates available, because right now providers are really struggling to try to figure it out. I mean, we have folks who are trying to DIY it themselves by looking at social security numbers. And they're like, we just pulled down all the weird looking social security numbers and we're just going to start there, which is crazy, right? Because I'm like, there's actually an identifier. It's not like these people, their status is not unknown, but it's not getting translated back to the providers.
Yeah, thanks for sharing that. I don't know Lynette, this is not your area. I don't know if you have any comments. You don't have to. I just want to give anyone else an opportunity on that one if you are interested.
I mean, just a little bit of basic logistic. To your point, yes. I mean, we know who is in which status, right? I mean, one of the things though that as we implemented the expansion populations to move the UIS population into full scope Medi-Cal, which was in managed care, when we did that, we moved those individuals into full scope aid codes. So aid codes is how we typically identify folks and what their resources are. In doing so, that meant they weren't distinguished, which helped decrease any different treatment that might occur based on that. So now that we're in a position that we have to unwind some of that and move folks out of managed care into fee-for-service, it means that aid code is not currently set up to make that easy, because all the providers get that kind of information when they check the eligibility in terms of that aid code piece is kind of the thing. That being said, with the implementation of HR1 and some of the other changes at the state, those aid codes that are specific to restricted benefits in terms of restricted federal benefits are coming back, and we'll be using those more. So there's going to be sort of a mix of when those aid codes start being used again, which then becomes a way of identifying those individuals. But there is some transition time, and depending on the age groups, that switch is going to happen at different times. So just to say, there is some of the back end infrastructure that is making adjustments too, but the same way everybody's feeling the timeline is kind of tight on everything, we're all feeling the timeline is kind of tight on everything.
Yeah. Okay. That's great. Thank you for that context. Okay. We're running a little behind. For sure, I'm hearing like very clear theme of one of the, opportunities and goals of some of this data sharing should be around, the urgency of the HR1 affected population, for lack of better terminology. So that is very clear. I think we'll definitely stake that up there, Julie. Were there more comments? Because we need to go to public comment and then end with, I just wasn't sure where. Yeah,
really quickly to kind of build on what Lynette's sharing, DHCS during their eligibility enrollment and all the work that they're dealing with, they're actually looking way beyond paper postcards, and there's big efforts to do stuff on the portals, to do emails, to do texting. So and I don't know if their capability yet for the UIS, just because it's, as Lynette's saying, it's going really fast.
Right.
But the intention is to do a lot more than just the paper for the broader, the ACA population, but also facing some of the same coding challenges.
Okay. Katie, Katie,
just super fast on the HR1 thing. If people want to know about HR1, please sign up for DHCS's coverage ambassadors page. Literally Google DHCS coverage ambassadors, put everybody on that list. They have a webinar, I think, on 6-month redetermination coming up at the end of the month. And a lot of the stuff that Julie just talked about, all of like the stakeholder communications, there's going to be a really big trusted messenger campaign. Philanthropy is sort of co-funding sort of the strategic development of a lot of those messages, and there's been a lot of work already done. It just hasn't been released yet. So get on that listserv, tell your people to get on the listserv, and call the enrollment folks at DHCS because they have a lot of information on this. So if you have questions, I would start there.
Okay, great. I think we're going to go to public comment. Katie, if you could put your card down, that would be great. All right, we're going to start in the room.
All right, real quick, two things, Deanne, with Intrepid Ascent. Agree with the committee members calling out the state data contributions, which CIE 211 referenced on slide 52. Some of our clients who are service providers have raised that to us in different arenas. And then also Intrepid Ascent had the privilege of working with CIE 211 and other members of the DHCS Path CPI under Colleen to create that minimum data set. So it is a resource that's publicly available as it was created, which Elena mentioned that working with a collaboration is available on our Path CPI public website for under a San Diego Resource Hub. So I just want to let you know that that one spreadsheet on slide 51 that Mark also mentioned is available publicly for access. Thanks.
Thank you. Okay, do we have anyone online?
None at this time, Dr. Sales.
No? Okay, thank you. Hi.
Thank you. Felix Su with Manifest Medics. We are a statewide qualified health information organization under the DxF. First, just to echo the topic that came up organically, the request or the urging to have the redetermination dates for Medi-Cal renewals shared more broadly with stakeholders who are involved in care coordination and outreach. We definitely would want to +1 that. As a QHIO, we are working on ideas to actually display that redetermination date in our record viewer so that care teams can actually act upon those dates as they're approaching, as has been mentioned. So we would really urge that the sharing of that data be expedited by the department. Secondly, on the broader topic about the work of the committee towards the HRSN data collection recommendations, as was mentioned in some of the other presentations, we'd encourage alignment with the Gravity Project, which is a national standards effort that is already building consensus terminology and FHIR-based approaches for social risk and social need screening. And rather than California developing a parallel standard, we'd really recommend that the committee explicitly reference and build on the Gravity Project work. This reduces implementation burden for organizations that are already aligning to those standards and keeps California interoperable with efforts happening across the nation. Thank you.
Great, thanks for that. Okay, no one else in the room. Akira, anyone else on the online?
So none.
Okay, great. So Jacob had some very thoughtful questions for this group, which we sort of got to, but not completely. And so what maybe we could do is pull them up, like go to that. Okay, so I think what we would like you all to be reflecting on and giving additional feedback on prior to our next meeting is going to be really like for this committee, like we are not solving HR1 here, but we can hear the priority that when we think about what data is high priority to be shared, it is like one of those priorities is around being able to support transitions of UIS populations. So that we hear. I think it would be great to have folks reflect on other goals that they feel like are really important that we should be focusing in on, because this is such a wide conversation and we got such great, examples of both how far things can come and how hard they are. It would be great to hear sort of priorities from you all. If you all would be willing to reflect and give us, I think Athena will prompt a little feedback after this meeting so that we can hone in the next discussion. Does that sound right, Jacob?
Yeah, that does sound right. We have a difficult task of getting to explicit recommendations and best practices by December, by the end of December, and October is really when we get into that. So focusing now on priority use cases and opportunities and issue areas is where we start, and we should have as much of that baked as we can before October.
So maybe we'll even entertain some in-between work like we did last time. Yeah. As long as they're in compliance with bag leaking public funds. Okay. Great. So I think, okay, with that, we're gonna break for lunch. We're gonna, this was an important conversation. We're gonna keep to our time, so everyone's getting half an hour.
I think we'll give a little extra time. We'll call you guys back. I'll give you like a 10-minute warning. So you be back in the room by 12:30-ish, just in case we get started, but we'll give you guys a little warning. You're encouraged to stay here and speak with your colleagues about non-DxF related items, and to get some time. So I know if folks ordered lunch, there'll be a way to grab that here. Otherwise, please quickly grab your lunch, come back, and we will get started around 12:45-ish. We'll probably give you almost till 12:45, but please be back by 12:30 so we can stay on task. Thank you. 10-minute warning. We're going to come back at 12:40. So 10. All right, everybody, we're going to come back together here. I might have to pull out my mom voice here if people don't start to listen. It is time to come back. Thank you to our folks online. I see you coming back on camera. As a reminder, committee members remain on camera. Should have noted that you can obviously go off during lunch, but appreciate you guys all coming back. We're going to go ahead and get started now. So if you are standing up and still talking, it's time to end those conversations, please. We're going to get started again. Do I need to do a countdown? Ready? 10, 9, 8, 7, 6, 5, 4. Andrew, hurry. You're going to make it back to your seat in time. All right. Okay, I know it's a little hectic trying to cut lunch slightly short, but we wanted to give you time to eat and nourish and grab caffeine and hydrate, all those good things to push through. We know it's a long day. We really appreciate everybody pushing through, but we have some more meaty topics to get into this afternoon. So we will go ahead and hand it over to our chair to reconvene the meeting. And we will do another roll call to reestablish our quorum. So please make sure you're here and ready for that. And so with that, I will hand it back to Dr. Sales.
Sorry. It looks a little emptier, but hopefully enough people are here. Okay, so I'm going to do roll call. Again, Joan Allen. Here. William Barcelona.
Here.
Colleen Chawla.
Here.
Yvonne Chung.
Here.
Do I need to say David? Okay. Aaron Goodale.
Here.
Katie Hydorn. Here. Andrew Kiefer.
Here.
Scott McDonald, are you online?
Your light hasn't
Thanks.
boarded yet.
Wow, you gotta, thanks for getting there early. Ali Motoresi, Eric Nielsen. Eric, are you online?
Here.
Thanks. Lucy Sands.
Here.
Mark Savage. Mark,
Here.
great. Kieran Savage Sagwan. All right. Jennifer Sales, I'm here. Julie Salis. Okay, no Lee. All right, we got a quorum to begin our afternoon conversations. So I think this is an exciting follow-on to our last meeting, I guess I'll preface. And also just wanted to acknowledge that of the work that went into that webinar that you both put together. I know it probably wasn't easy to get 5 or 6 states to all agree to a time, and all of the comments you might have had for how to control them into giving really helpful information. But I went and I found it incredibly valuable, and I know some other committee members were on it because I saw them. And for those of you who aren't, we're going to spend a lot of time talking about this. So I would just recommend you do watch the video if you haven't, on your ride home or something, because I think it really opens up a little bit in terms of like how we kind of frame where we want to go and understanding some of the different examples out there about different ways to get there. So thank you for that. I'll pass it on to you.
Okay, great. Yeah, no, we do have a fun conversation planned for this afternoon. Let's just jump to the next slide. We're going to get right into it. So as a reminder, we are talking about strengthening the QHAO program in 4 separate conversations between June and December. We, in June, shared an overview of the QHAO program, started to talk about a number of the issues impacting that program, and we specifically highlighted how those issues impact a specific example, which was event notification services. Today, we are transitioning to actually discuss some potential solutions to address those issues, those challenges. And in October, we will actually continue that discussion, refine those into recommendations that we will formally vote on. And in December, we'll talk about how we might start to implement those recommendations that we set in October. So that is our path here. Let's go to the next slide. Today's goals, really, we are this afternoon first going to recap the QHIO program issues that we introduced at the last meeting. We will talk about the approaches that other states have taken to address related issues, and we will describe some of the actions that our department intends to make to correct those issues. We will then take a 15-minute break before we will actually open it up to some potential solutions we might consider for this program. We have 3 to bring today, and we'll also discuss opportunities for others. We can go to the next slide. So let's just reground ourselves. You may recall 2 goals of the QHIO program. First is to establish statewide exchange of health and social service information, and the second is to help participants meet their DxF requirements. Next slide. Now, in June, we discussed 6 issue areas affecting the program and impacting our ability to meet those 2 stated goals. Those revolving around sustainability of the different organizations, reciprocity and exchange between them, voluntary adoption, service gaps in the program, trust concerns in the program, and oversight limitations. Now, we can go to the next slide. I am going to turn it over to Dr. Rim Cothran, who's right here to my left, who's going to talk about our work meeting with other states, convening other states, and how that has shaped some of the potential solutions you might hear today.
Thank you. I do want to thank everybody that did attend the webinar in July. Yes, it was great to get questions. I appreciate you being there as well. And it did focus on a particular example of exchange, but our research in talking to other states reached out into other types of exchange as well. And I want to be able to touch a little bit on those. We've summarized in these 2 slides what we learned from the states at a very high level. We'll go through this quickly. And then the following slides talk a little bit about how what the other states are doing might address some of the issues that we've seen in the QHIO program. In this slide, we see that some states have chosen a single statewide entity to deliver exchange, while others, like California, have chosen to meet statewide exchange needs using a number of different organizations. They might be not-for-profit HIOs, or they might be contracted for-profit entities. What's interesting is that TEFCA follows that model as well, as using multiple organizations rather than a single entity. Some states have also chosen to work with a single state-operated service. However, most of the states that we talk with, like California, are using separate organizations, either not-for-profit organizations or commercial organizations, to deliver services under the management or governance of a state body. Again, TEFCA also follows that model. If we go on to the next slide, here we see that a number of the states are providing funding for the services. In some cases, it's complete funding of all of the services that are being delivered. In some cases, it is some partial funding to support the services. In the case of North Carolina, for instance, the services are completely delivered by the state and therefore are completely state funded. Same for Maryland, who contracts for all of theirs, whereas a number of organizations are using other organizations that may or may not get significant funding. California and Massachusetts are both examples of organizations that provide oversight or governance, but without operational funding. California's funding so far has been largely limited to technical assistance and onboarding grants rather than operational funding. TEFCA again follows this model where funding is not provided by the federal government to do anything more than governance activities. Most of the states that we've talked to have some statutory or regulatory requirements for participating in exchange and require use of the intermediaries that they designate or the statewide services that they've designated. California is actually unusual in this respect in that it requires participation while making the use of a designated entity like a QHIO optional. Even TEFCA, where participation in TEFCA is completely optional, if you do participate, you're mandated to use one of the designated entities for that. Just briefly to summarize what we're hearing before we turn on into the QHIO issues themselves, California is not unusual in following a distributed rather than a centralized model. One of the questions we often hear is, well, why doesn't California just do a centralized statewide HIE like all of the states do? Well, many states do not follow that centralized model. Second, California is not unusual in designating independent intermediaries to operationalize HIE rather than running a central state-operated service itself. California is not unusual in requiring participation in HIE. Many states require participation, but California is unusual in not requiring the use of designated intermediaries. And that's one of the places where we found that really departs from a lot of the approaches in other states.
And Rim, can I just comment? I mean, I think it's helpful to see where we are same and different, and that clearly will feed into some of the discussion. I guess I also think, like, I took away that there, you have to orchestrate all of these components together to work. So if you don't have clear markets and you don't provide any safe funding, like, there's a lot of interaction of these components. And so when I look at those models, I'm thinking about how did they put these pieces together to sort of optimize the outcome. And so I guess for our framing, and I know you're going to go through the barriers, I just would encourage folks to kind of let your head do the exercise of, like, well, like, there's a lot of dependencies and interdependencies. So just sort of like, if we're thinking first and foremost about, like, the frame for how, the system should operate, like, what are those components that we want to explore or take, like, from other states? Clearly the Band-Aid is a different differentiator, but there probably are others. And so just wanted to kind of, like, plug that in as people listen to your next section.
I think that's really important. And I'm going to be in the next few slides going through again the issues one at a time, but considering the issues in aggregate is also going to be important to us. And that's part of what Jacob in part 2 will be talking to, is how do you take and solve potentially multiple unit issues with specific actions that we can take. So keep that in the back of your mind. I think that's really important. Thank you for that. Let's go on to the next slide. So we've talked a little bit about the different approaches and characteristics of those approaches in the states. I want to now pivot to talking about the separate issues that we reviewed in our meeting last time. Jacob touched on those. There are 6 issues that we've identified with the QHIO program, and let's talk about each one of those. In each of these slides, you'll see on the left-hand side, there's a summary of the issue. That's mostly what we talked about last time, and I'm not going to reiterate that. I'm also not going to read the right-hand side to you, but I think that there are some important things to draw out from that and the contrast between what other states are doing and what we're doing here in California. Although this mostly concentrates on what other states are doing, want to throw in every once in a while what's going on with TEFCA. We do work in an environment where the nationwide networks are important, and our stakeholders continue to call on us to make sure that we're aligned with TEFCA. So I want to make sure that we touch on what TEFCA is doing in these areas as well. So first of all, program issue of sustainability. Required use of a single statewide service operated either by the state in North Carolina or contracted by the state in the case of Maryland, or perhaps inherently sustainable. They are the only game in town for a mandated participation in HIE. Massachusetts and New York instead qualified multiple intermediaries by exchange type. In Massachusetts, multiple commercial HISPs for direct messaging, or event notification service providers with unconstrained geographies. And in fact, New York is moving from a regional approach of their qualified entities, the equivalent of our QHIOs, that are bounded by region, to a couple of qualified entities specifically designated For event notification, their first foray into specializing QAs around certain exchange types. Both Massachusetts and New York require hospitals to use the designated services for events, for example. And Massachusetts supported sustainability by selecting intermediaries that had already existing business in the state for that exchange type to make sure that the investments had already been made by those intermediaries. As we discussed in June, the QHIO program does not include some of these characteristics of other states. For instance, we don't have minimum operating thresholds that QHOs must demonstrate for any particular exchange type, and required use of the designated intermediaries is not part of our model. Importantly, many but not all states support sustainability through state funding. So sustainability does not necessarily require operational funding by the state. While it's not on this slide, just want to mention that TEFCA also supports sustainability of QHINs through demonstrated capabilities and required use. So common to some of the states, TEFCA shares that same model. Let's move on to the next slide, please. For the issue of service gaps, all of the example states that we talked to establish intermediaries by exchange type. Many cases, they require an intermediary to offer all exchange types, but not always. In fact, New York is the only example that designated services regionally. All other states use a single statewide service or multiple cooperating services to provide statewide service. New York is actually transitioning into a mixed model where they have both regional and statewide organizations providing services. TEFCA is somewhat unique in that it only supports a single exchange type, so it's a little bit more difficult to think about TEFCA in this space. TEFCA supports only query-based exchange at this time. That may expand in the future, but that's all they do today. Whereas all of the state examples include requesting information, pushing information, and event notification, a broader group of exchange types that more aligns with what California and DxF are doing. Since HIOs in California developed organically and pre-existed before DxF, some of them over decades, they have developed to support or specialize, they may have developed to support or specialize in different industry segments. Some of the QHOs specifying certain stakeholders they try to support in different exchange types. Some of them specialize in particular methods of exchange and or in different geographies. Some of them specialize in delivering services in a particular region of the state. Since our business developed independently of DxF requirements, some forms of exchange required by DxF and the QHIO program of all of the QHIOs may have received limited focused investment by the QHIOs themselves, which really leads to some of the service gaps. Let's go on to the next slide. On reciprocity. Many states offer a single statewide service where reciprocity is simply not a concern. North Carolina and Maryland are good examples of that. Massachusetts established a minimum level of existing business in order to qualify to be a designated entity exchanging event notifications in that state, or have an existing business in direct messaging in order to do push notifications in that state. So that means those organizations have already made the investment. They chose to make the investment themselves and enter into that business space. And all of them also have valuable data to exchange with the other members of that service. So those are big differences potentially from the QHIO program here. New York established a statewide service that they require all regional QEs to connect to, and then use some designated QEs to then distribute notifications as an example there. As we discussed in June, the QHO program does not include some of these characteristics either because QHOs grew organically. Not all QHOs offer equal support for all exchange types. Some have limited investment in some exchange types, and therefore some have limited data to share with other QHIOs for certain exchange types. Based on the differences in the industry that they may serve, the portion of the industry that they may serve, or exchange models that they've chosen for their own business to focus on. These imbalances, frankly, have also hindered collaboration among the QHIOs. While it's not on this slide, TEFCA follows California's model by allowing QHINs to specialize on a market segment, but enforces a requirement for all QHINs to exchange data with each other. And I think it's yet to be seen how well that'll work within the TEFCA model. Let's go on to the next slide. A little on trust. Quite frankly, there's very little publicly that either states or TEFCA are sharing on how they're addressing the recent concerns over misuse of health information. So there's just not much that we can learn there. However, most states provide services directly or through state procured intermediaries that have some form of verification of the participants that are within the exchange. TEFCA, in particular, was brought up at the last meeting, has an established process where the QHINs are required to vet and sponsor their participants before they can be admitted to TEFCA. QHINs may raise objections about the admission of any participant, and we probably should note that while California requires certain entities to participate in DxF, TEFCA is completely voluntary. So if you fail to find an organization that's willing to sponsor you to join TEFCA, that does not present a compliance problem for you. Whereas California, certain organizations are required to exchange data. As we discussed in June, DxF has established a process to verify participants. Jacob talked about it a little bit more this morning, and it'll come up again in a few minutes. Next slide on voluntary adoption. Many states have legislative or regulatory requirements to use single statewide services or designated intermediaries. As we said before, most of the states here require use of those intermediaries either through legislative or regulatory engagement. In Massachusetts, for instance, the event notification service requires that hospitals use one of the two designated entities, but it leaves complete freedom for those receiving notifications to choose any method that they want. Michigan promotes use of services through pay for performance rather than regulatory levers, and that is working well for them too. As we discussed in June, use of a QHO is optional for DxF. While it's not again on this slide, TEFCA requires use of a QHIN, as we know. I want to take just a second, if we have a few minutes, for a sidebar here. One of the questions that you all asked us last time was, so what is going on with the organizations that are not choosing a QHO today? So I thought I'd lay on just a few statistics there. Use of a QHO varies by exchange type. We have 3 different required exchange types in DxF: request for information, information delivery in response to an order or referral, and event notification. Approximately half of our participants are using a QHIO for requests for information. About 20% of them are using a nationwide network or framework. The balance, about another 30% of the participants, are either using an intermediary that is not a QHIO or using point-to-point connections, potentially with every other organization in the state, not necessarily a sustainable process, or are declaring that information, that request for information doesn't apply to them. Just to note that request for information is required of all participants that maintain data. So that should be a very small fraction. If we turn to information delivery, very, very few organizations are using QHIOs for information delivery and are not using nationwide networks for information delivery either. While TEFCA doesn't support it, eHealth Exchange does, and organizations are not using eHealth Exchange much for information delivery. Now, that may be due in part, at least, to the fact that labs and pharmacies, 2 of the areas where you'd expect sending information unsolicited, already have a large number of point-to-point connections already connected into EHRs and therefore didn't need the help of an intermediary for that. And then as we talked about in June, about 80% of hospitals use a QHO to send notifications to admissions and discharges, and about 85% of participants that receive notifications receive them via a QHO. Since nationwide networks don't support event notification, that means that the balance there are using point-to-point connections. And we talked last time about what the magnitude of even that 20% is, that an organization that is like a hospital that wants to send notifications to every participant, we're probably talking about thousands of connections that they need to make because of that 15% that don't use QHO. Thank you for giving me a little time for that, but I wanted to at least give some information there. Just have one more slide. Do you want to pause here to take a question?
Are you getting it from the QHIOs, or is it through the spreadsheet that shows like what everybody's connections are?
So the data that I've been talking about here come primarily from two different sources: from the participant directory, where people have declared who they use. So no, we're not asking the QHIOs for that information. We're asking participants to declare their use. And the other source of information is a participant survey that we conducted earlier in the year.
Okay.
So this is what organizations are declaring that they're using. All right, oversight limitations. We talked about that as one of our issues last time also. Massachusetts actively monitors adherence to a collection of exchange standards enforced through contractual obligations. And that's really how they manage it. They're with commercial entities, and they have contracts with those entities that require use of certain standards and mandatory reporting to ensure that they're compliant with those standards. All states that we surveyed require commercial or HIO service providers to support a single set of technical and operational standards. All of them do. As we discussed in June, DxF has a lot more flexibility. It establishes minimum standards among participants, but it allows QHOs the flexibility to collaborate to establish standards for how they would exchange with each other. It allows QHOs the flexibility in how they exchange with their customers. And we use an attestation approach to qualification that has frankly made it difficult to assess whether QHOs adhere to the minimum standards among participants. Other QHO programs have hindered collaboration here as well. So the QHOs have not come together successfully in all cases to identify the standards and that they'll use in exchanging data with each other, although they're continuing to make progress in that area.
Hey, Ram, can I ask a quick question?
Sure.
Clarifying. So in the current state for us in DxF, so you're saying that the opportunity is for the QHOs to agree themselves and amongst themselves on standards?
That's the way we set the program up,
And
yes.
a test. Okay. So is there any context as to like giving everyone else some other way? Like do we know why we did that? I mean, I'm just curious. It's a big difference.
So it's a historical question, but at the time, rather than being prescriptive without a great understanding of the capabilities necessary of all of the programs, the thought was, we'll let the programs figure it out themselves. Is what can they most easily support to meet the objectives? And that has not served us particularly well.
Okay. And I'll just say, we'll talk about this briefly in just a moment, but one con to defining standards is the risk of limiting innovation. If we define standards immediately, they must stick to those standards, and those standards may not evolve until the state evolves the standards. And so early on in the program, there was a hope for the QHIOs to collaborate with one another and help define those innovative standards amongst them. It's I think clear to us that other states who are enforcing single sets of standards are have a more effective approach in certain circumstances.
One more point, but before I make that, I don't want to mislead anybody to thinking that the QHOs aren't working together. They are, but the program's been operating for a long period of time, and some of this data is still not moving among QHOs. So this approach hasn't been particularly successful. Last point I wanted to make was then again about TEFCA. TEFCA has very strict standards that it is established and published for how QHINs must exchange data with each other. And they're very explicit there. Where they have allowed flexibility is how those QHINs exchange data with their customers. And so they don't prescribe those methods. And with that, then I'll turn things back over to Jacob, where he'll lead us through some discussion of what we learned from the states.
Hey, Jacob, I'm just gonna, it looks like, do you have a clarifying question, Julie? Yeah, let's maybe just let her ask. Is that okay? Yeah, Julie.
Yeah, I think it's more a question of maybe we need more analysis, because my familiarity with the ones that are statewide is that their ability to share data through social determinants of health data is at a much higher level than at our model with QHIOs, because the statewide ones are actually, they have access to all their state agency data, and so that the data is part of state agency data sharing. And I'm wondering if that could be addressed in the if that's something that we could like recast for the service gap, like add that in there as an important part of the analysis, is the ability of the states to bring in a lot more social services data than the selective QHIO model that's not centralized. Is that something we can?
I'm sure that that's something that we can explore. Our research so far has really been focused on health information, and but I think that that's something that we can explore as well. Sure, thanks.
Okay, and we had one other comment from Mark. So you want to read it?
Sure, Mark, I don't know if you want to come off mute and just make your comment.
Sure. So I appreciate Rem's comment. I was throwing out that prescriptive standards can be a floor, however, not a ceiling. And as a floor, you can also allow for innovation and higher standards above that floor, and that's the federal approach right now. Thanks.
All right, well, that transitions us into the next phase, but we're not going to do a ton of solutioning just yet, right? We're waiting for you, Jacob.
You got it. Thanks. And Mark, wonderful call out. We'll get there very, very soon. So we just wanted to open up for discussion with the committee, just in terms of sequencing for this afternoon. So we're going to talk about just what you heard from the solutions that other states have taken, what you think resonates with you and might apply to this program, and anything that you have heard or seen from the other states that maybe we didn't mention today. So that's what this discussion is really for. Then we'll take it to a couple of solutions that HCI intends to implement in this program to address some of the issues. And then this afternoon, we have 3 potential solutions to actually review and consider together. We're getting explicit on these solutions instead of staying at the 20,000 foot level. But here, this discussion, we're at the 20,000 foot level. What are other states doing? What have you heard? What resonates? What do you think applies to our state in our program in particular? So we'll open it up. We'll leave that a little bit open-ended.
Ali.
Thank you, Dr. Sales and Dr. Catherine. I just, I was looking at the population of the states, and just because it's relevant to, when we talk about North Carolina and Maryland, the population is as small as LA County in some cases, smaller than LA County, and also the geographic area. You mentioned that, QHIOs came up as a regional HIEs organically, and they help in kind of taking the DxF to the next level. So I want to kind of emphasize on that, emphasize on this, the role of the regional HIEs and as opposed to the, statewide HIE, because we hear that. And I also just remember that, about 12, 15 years ago, 2 large health plans tried to implement the statewide HIE, in California. And, they did not have much success. And actually, the regional HIEs basically grew pretty much the same pace as the statewide that was established at that time. So I think the market has spoken as to which model is better, because the regional HIEs are, because the problem we are trying to solve here is care coordination. It's not about, because eHealth Exchange and all other national networks are, providing that information, sharing information across the nation and in California. But it's that care coordination effort at the local level that is critical to the patients and helping providers taking care of the patients. So I want to kind of take us back to this: what is the problem that we're trying to solve? And to me, and to us, and to our community, it's been the care coordination at the local level. And I know, some people travel, and I'm in Sacramento, and I may end up in the ED, but that's 20%, maybe 20% of the visits. The other 80% happens at the local level that requires the coordination in the disparate kind of health system network to connect the social service organizations and the providers and all these ancillary care providers. And QHIOs, regional QHIOs, are designed to do that, because that's how it started and that's how we are growing. And so I just want to kind of put it out there as to when we compare ourselves with other states, California is way different and much larger. And there's a local need that needs to be addressed, that cannot be addressed with the statewide HIE.
Okay, thanks for those comments. I guess I might just say, that is the history, and we're here. So I think it hasn't completely worked. So I think the question is, and what needs to be different, I think, is the frame that we're trying to take for the conversation. And I think the reason New York was in there, the team pulled New York, was explicitly because it was a large state with a similar, scale population, and it has a combined model, to your point. Okay, Julie.
Yeah, thank you. I wanted to just talk. I have some experience with one or more of these state centralized, and their ability to really evaluate human experience is really important. So, for example, in one state, they did a data match across their homeless system of care and their Medicaid, and they found people who were kids who were on Medicaid who were homeless. And then they prioritized the homeless services to those families, because Medicaid and the agency, the state, did that work. And right now, one of these states, because it has this centralized set of data, they know who's homeless and they know who has Medicaid, and they're going to be able to tell the homeless system of care what their renewal dates are without needing any, they need to redo their scripts for how they do it, but they don't need any new technology to do that. And going back to our regional conversation that we had this morning, this is where we are now also, not just looking and reflecting back about different systems, but we're very different time of people are losing their food benefits, people are losing their health coverage, and they're not necessarily just health. We're talking about people who are going to lose their access to health because of these new rules. And so I really like the way to build that. It builds in state information from CDSS, from DHCS, from behavioral health, in a way that our system the state isn't part of that at all, really. We're not sharing all that data through the QHOs. It's very local, but a lot of our problems right now are bigger than local. So I think there's a balance that we just have to think about.
Thanks, Julie. I think we have Mark on the phone, and then Andrew will go to you.
So I really appreciate the survey. I wasn't on the webinar. I appreciate being caught up on that. And sort of what's striking me is the number of states that are working with either sort of a centralized approach or sort of hearkening back to my earlier comment, a minimum floor of standards. So it's not clear to me that those two can go together. You can have centralized, maybe a federated or regional approach, but still with a common minimum standard for the state or area. And that resonates with me in my experience in this area. I mean, we began this effort in 2009 because the market wasn't working. So we had HITECH Act. It took that, and sort of fast forwarding to an example that's current today, we're finally beginning to make some progress because people are working around fire. And if that hadn't been put into place, we might still be further behind. So what I think I'm seeing from this is, and I do understand the importance of sort of local and regional understanding of things, building from the ground up, where people know what their needs are, and they may not be the same as in other parts. That resonates with me, but having everybody meet a common set of standards is also resonating with me, and I don't think it's an either or solution. I think it's a both and solution. Thank you.
Thanks, Mark. Andrew.
Yeah, thank you. Appreciate the opportunity. So we're one of these organizations that created statewide health information exchange, and we did it for exactly the reason I think that Ali pointed out, which is care coordination, healthcare operations. For us, we operate in every single zip code in the state of California. We have members from Crescent City to San Ysidro, right? Everywhere in between. And for us, having consistent and standardized data sets, information about our members is central for us to do all the things the health plan does in partnering with our providers to deliver the care. So that as we embarked on this effort, there's an approach, and the state, and we ultimately supported it, got us to where we are today, chose the path we're on. And I think it goes to Mark's point. We went down a path of enabling the QHIOs to do what they're doing, figuring out essentially on their own. But absent that, we haven't maximized as a system how that sort of decentralized approach works optimally. And so if that's a common set of standards, so be it. We'd be supportive of that. But the point is that there are gaps still, and we have great partnerships with three. I'm sitting here with three of them today, actually. So I got to be mindful of what I say here. But we have fantastic relationships, and we value them. But there is still that baseline healthcare operations piece that a health plan faces that hasn't been fully met in our current environment.
Thanks for presenting that population view. That's helpful. Okay, Ali, we're going to go back to you.
Yeah, just regarding the social service or access to social service, but if we have in California a strong QHIOs that can operate and work with each other and close the gap, as you said, Andrew. The state can share the social service information with us, and then we can share with the rest of the community and among ourselves. I think that's the missing piece. Right now, we are working with, we're trying to work with the state to get the, access to the renewal day information. So now that we have such a wide network of health centers, IPAs, and so on and so forth, that they're currently doing the outreach, they need this coordination layer at the local level. So first of all, there's no duplication of work. Several organizations calling one member, and then also tracking of where they are in that enrollment process. That's you see, the QHIO infrastructure can be used for many purposes. And it would take the collaboration with the state and with the counties to bring it all together. But the point is the infrastructure is there to act at a locally, because how we keep mentioning this, that how medicine is practiced in Southern California is different than Northern California, so on and so forth. So just want to emphasize on the infrastructure is there, and it can be expanded to many, many use cases, including public use cases that we are not talking about here.
Okay, great. We are gonna go. What are we doing? Lucy, and then Yvonne, and then we'll go. Is the public comment now? Oh, okay, and then we'll go to public comment. Okay, Andrew, was yours still up, or is it from before? Okay, got it. No problem. All right, Lucy.
Thank you. So I'm just going to go back to your question, Jacob, around the approaches of other states. I just wanted to point out that I really like the specialization by exchange type. So right now with our health centers, we're hearing a lot of, we're getting data from QHIOs. It's a lot of data. We don't know what to do with it. We don't know how to take action on it. And so I think that really figuring out how do the QHIOs specialize in specific areas of data exchange so that when the data is exchanged, health centers can actually act on the data. And then the other thing that we do see is a lot of timeliness, completeness, reliability concerns. So I really, I think it was New York where they had that specialization. I really value that.
Thank you. That's helpful. Okay, Yvonne, and then I'll go back to you, actually. I guess you had a couple slides. Yeah, sorry.
Okay. Thanks, Rim. I actually had a question. I'm not as expert, I think, as a lot of people in the room. Can you talk a little about, Rim, if we let things go on the way that they are, what are the risks, right? I think that's what I'm still trying to get my head around is other than, I mean, I understand that it doesn't sound ideal to have, this many QHIOs, but in practical terms, on care coordination, like what's the downside that we are risking by continuing the current system? And then what are the kind of the most immediate risks, like looking at all of these things, what's our biggest problem? That's the thing I think I'm trying to wrap my head around.
In our last meeting, we used a specific example of event notification to talk about, what are the consequences of some of the issues that we're seeing. And so it's probably the easiest place for me to go to illustrate some of these things. So for instance, one of the things we saw is because of a failure for good statewide exchange due to reciprocity issues, sustainability issues, and oversight limitations, it meant that organizations were having to reach out to multiple organizations, multiple QHIOs, and additional intermediaries in order to just get the notification statewide. So statewide exchange is absolutely at risk. We're also seeing that it's difficult because of the way we've set the system up. It's difficult for us to provide decent oversight of the QHIO program and understand what corrective actions need to be taken. And so continuing to move things forward in any organized way, as opposed to letting each of the organizations continue on their own path. It's the lack of coordination and organization that's difficult for the state to.
And that would be between, sorry, so are we talking about coordination between the QHIOs or between users and their,
primarily between the QHIOs is what we're talking about. Okay. It speaks a little bit to what Ollie was saying before. It's coordination to meet some of the advanced use cases, but even the use cases that we have here now to realize that effectively across the different QHIOs.
Like, just to translate, so I mean, the way I think about it is, if you don't want to have 5 or 6 or 10 or 20 points of contact to get all the parts of information you need, like the whole value proposition of the DxF is like, I could sign up with the QHO and get all the things I need here, and I'll give it back, and it gets distributed to who needs it. And so, like, if that isn't happening, like if that exchange in the, in the system and then in the framework of the QHOs isn't happening, then you would have to go to every single one to get back what you need. So, I mean, I think that's the burden too. Fionn.
Just a fairly quick question. I'm trying to think about timing. And if we make a change now, how many years will it take the system to actually stand up a substantial change to how we are structuring QHAOs? And I'm thinking about that in terms of our timing of also really ramping up signatories. And is there any, what are the frictions of attempting to do those things at the same time versus is it helpful to do them at the same time so that we come out the other side of this with a more logical system? And just, is this 6 months, 5 years, 10 years?
Yeah, and I think after the break, we're going to talk about some potential solutions and the timing of some of those potential solutions. When would it actually start to impact the community? When would it actually take effect? What I'll say is this program is quite agile and flexible now. We today see that QHAOs have 50 to 60% of our current DxF participant population. And so getting better organization of these QHAOs, better oversight, solving a number of these issues automatically right away gets us 50 to 60% of the current market of our participants, which is a good first step. It doesn't take us to that last 30 to 40%, and there's more work to be done there. And I think that's the long tail that we're going to talk about after the break.
Okay, that's helpful sort of staging.
All right, I think we're going to be back to you for your last two slides.
Okay, great. So we have a break coming up, but just to say there are two solutions that HCI intends to make to this program that we wanted to share today. After the break, we'll talk about some potential solutions we might consider, but we'll jump to the next slide. The first, certainly no surprise from this early part of the conversation, that we intend to establish and begin mandating QHAO to QHAO exchange standards as a part of the program. This is a first for us here. As we mentioned, a lot of it's been voluntary standards based on those that have been agreed upon between the QHAOs. We certainly, I think, Mark, hear your feedback loud and clear that there is a lot of value to establishing a mandated floor of standards and allowing for innovation on top of that floor. But I'll just pause in case there's any questions on this approach.
Yeah, two quick questions. What would be the process for establishing the standards exactly? Like who's going to make that decision on what the standard is? And then secondly, how would that be enforced?
Wonderful question. We have a pretty good relationship with our QHAOs and have formally had a wonderful process, meeting weekly to establish things related to this. So in terms of how we would actually implement it, we'll talk more in December about specific implementation. But the reality is you just got to get folks in the same room a lot of the time and start working with each of these QHAOs to talk about what is feasible and what is going to be best fit for our participants. In terms of how we would actually enforce these, we have some early compliance measures and mechanisms for this program. These are published on our webpage. So we can share out some resources regarding today. How do we initiate a compliance review against a QHAO? What happens if a QHAO fails that compliance review? What does corrective action look like for that QHAO? So all of that is already defined. We have the framework there. And really it's about kind of exercising that muscle with this new requirement.
Right. All right. I think, is that any other committee? We're going to go to public comment if we don't have any more committee. Oh, no, you've got one more. I'm sorry.
No worries. One more. Okay. So another change we intend to make to the program we're calling it voluntary exchange during participant verification. So the idea here is we implemented a new participant verification standard operating procedure. We brought this to you all, I believe it was at the last meeting, and received a robust amount of feedback that we've taken back and we're iterating on. So this is version 1 of our own state participant verification process. And what we'd like to implement along with this to build trust and better trust in the program is to allow QHOs and other participants to suspend exchange of health and social service information with signatories until that verification has been complete, until the state determines that they are a legitimate health or social service organization, governmental agency, or vendor. And the goal of this change is really to allow HCI to start to detect bad actors before exchange occurs with those actors. And just at a high level, what this would look like, participants and QHIOs must respond to requests for information from other verified participants, of course, for required purposes and permitted under law. They may respond to requests for information to non-participants, and they may respond to those who are actively undergoing a verification, but it would not be required. And they should not respond, at least under the DxF, to those that failed their participant verification. So we would have a defined process for how to exchange with someone who's unverified, or really how to exchange with someone who's currently going through verification. We would outline this and modify our standard operating procedure. Any questions on this?
I think Mark's on the line. He has a question.
Mark.
Maybe more of an observation. One of the real advances that I appreciated about the DxF was to bring in CBOs and social service organizations. So you have a range of organizations with capacity to respond to a request for verification, for example. I think the devil's going to be in the details, where there are going to be people who are working hard to provide care, may not have the administrative, the vice presidents and so forth in hand to be responding to things like that. So I think how you implement this and how you provide a range of ways to respond will be really important to meet the needs of all Californians. Thank you.
Thanks for the feedback, Mark.
Okay, well, we have some more to talk about, but first, I'd like to go to public comment. Does anyone have a comment? All right, hi, in the room.
Thank you. Felix Su with Manifest Medics. We are actually the aforementioned organization that, in fact, is very successful in our statewide reach, both in terms of our service model and of the capabilities that we offer. And really, we recognize, and we're structured this way because on the ground, as many of you can appreciate, whole person care cannot and really should not be confined by regional or county boundaries. Local care coordination, isn't dependent on whether a platform or network is regional in organization. And in fact, network effects by nature grow with the size of the network. Therefore, it's oftentimes the inverse, that the quality and the efficiency of the services that we as health data networks are able to provide to providers, to payers, to CBOs, and to others who are involved in whole person care scales with the size of our infrastructure. And ultimately, we see in the lessons from other states, from Maryland to North Carolina to Arizona to Colorado, that the statewide approach oftentimes is the optimal endpoint for reaching that scale. Secondly, really quickly on establishing QHIO to QHO exchange standards, we 100% support this action by HCI. We just want to again reiterate that it has to include FHIR API-based querying for ADT exchange, and to really retire the approach of periodic roster sharing, which is outdated, insecure, and operationally burdensome. And we actually prepared a memo documenting the benefits of a fire APA approach that we share with HCI, and we are happy to also provide printed copies afterwards to committee members that are interested. And hopefully it will help inform your discussions for the creation of that eventual fire roadmap. Thank you.
Great, thank you. We're going to go, Akira, is there someone on the line?
Yes,
For
we have
public
two
comment?
hands raised right now. Mr. Fate, you can unmute yourself now.
Thank you very much. Can you hear me?
Yes, sir.
Outstanding. So certainly appreciate you letting me comment on this. Jonathan Fite from Beyond Lucid Technologies, and some in the room know that I work with the FIRE, not FHIR, as Felix was just referring to, but FIRE, as in fire services and ambulance services in our fine state. And I want to, if I may, go back to a couple things that were mentioned during the previous session. I think Julie, I apologize if I misattribute that, but I think it was Julie who was talking about missing information related to things like food insecurity, housing insecurity. Please, someone let me know if it wasn't her. But I want to tie that comment to RIM's discussion around what other states are doing to kind of congratulate California, because California is currently, by my knowledge, as someone who surveys this entire field of fire and ambulance service engagement with health information exchanges, the only state in the union that is mandating interoperability in an active way for fire and ambulance services. Other states, including North Carolina and Massachusetts and New York, in fact, all three of those permit and offer a voluntary path, as this community did during the AB 133 days, and basically said, if you'd like, please participate. But they don't mandate it, whereas California has mandated it. And so that is a wonderful thing, but it also helps to serve that gap that was identified in terms of those social service needs. I, for better or worse, have been describing the current social period that we live in as the golden age of ambulances. And it's getting worse, not better. As more people lose their jobs related to things like AI, certainly that's hitting California uniquely hard. As more people are out of work and lose their access to health insurance, as policies make it harder for people to get on the Medicaid rolls, all the things that are being discussed, healthcare tends to get pushed off, particularly things that would be preventative maintenance, so to speak. And therefore, more people tend to get sicker and not get care because they don't know that if they can afford it. And so they call 911 when it finally hits the point where they can no longer ignore the pain or they can't get out of bed. So this is a moment when the ascendance, so to speak, of ambulance services and fire services is upon us. It's not a good thing from a social perspective. I work in a part of this ecosystem where the worse things get, the more these guys are needed. But to the extent that this state has reached out to the fire and EMS community and said, we want your information, we need you at the table, they are a source of information to close those gaps. Fire and ambulance services, which are part of this ecosystem, but use different data structures and are very confused right now about what their responsibilities are and how to engage with this ecosystem of the DxF, are a source of truth in terms of who is living on the street, who is newly on the street, who has been there for a long time, who is underhoused, underfed, chronically malnourished, unable to leave their homes, afraid to leave their homes. Right? All of this types of information that crosses the clinical and social line exists in the data sets that ambulance services capture, that we in our ecosystem swim around in, and we would like to play more actively in the DxF ecosystem. There is a rule to do so, we know that, but the how is getting lost in some translation. Fire and EMS in California is a massive part of our public health ecosystem, and there is still confusion about whether they participate, whether they need to, how to do it. Does this mean everybody has to start using Epic? Right? There's all kinds of confusion. So I would encourage this group, to the extent that you can, to look to your fire and ambulance services to the extent that they can help to fill in the gaps, if only we talk to them. I am here, I guess, representing that ecosystem, as I've sought to do on multiple occasions. But there are a lot of us in this ecosystem who want to participate, who have been a part of these conversations, sitting next to RIM in the offices since 2012 to 2014, when this was first discussed way at that time. We've been trying to participate for a very long time, and thank you so much.
Yeah. Okay, thanks. Sorry, we got a lot of comments, so we're trying to stick to 2 minutes. Thanks for weighing in. Okay, we're gonna go back in the room. Deanne.
Hi, Deanne. I'll be quick. Hi, Jonathan. Couple things. A little bit. QHIO program definitely needs to evolve. I think everybody's on the same page and maturing, and it's following that course. Similar to Ali, who looked at the geography comparisons of the other states and populations, it's really insightful to look to other states and other ecosystems, Europe, even that kind of stuff. But California's 5 years. I looked at the years, real quick lookups. Maryland, 17 years. North Carolina, 16 years. Massachusetts, 13 years. So time. We want to go faster. We have HR1, this and that and everything. So give it a little bit of grace on the time as well. We were doing DxF as a sprint. We've learned it's a marathon. So there's still years ahead of us, even though, as Mark said, we all back in 2009, but DxF is 5 years old. QHIOs are the movers of the data. They're not intended to be the housing of the data. So we're putting a lot of eggs in a QHIO basket when they're moving the data. So back to the conversations earlier about the state and who the other data parts, or to Jonathan's point about EMS data, not everything lives, and even the data, the stats on what data the responder, the participants are using the QHIOs. Last point on the verification, that seems like verification, great idea, great process, this and that. Seems more DxF than QHIO program. It's verifying the other participants. So I just think it's a good thing, but it's more broad probably than just the QHIO program. Thanks.
Okay, thank you. Akira, we had one more person on the line. Is that right?
That's correct, Dr.
For public
Sales.
comment.
Corey, you can unmute now.
Great. Hi, good afternoon. This is Corey Mertz with Point Click Care. Point Click Care supports the goals of the DxF and a statewide approach to event notification. We've been supporting our California customers with data exchange for over 10 years without state funding, and provides SNFs with scalable, nationally certified secure data sharing methods. I think as we heard again today, and definitely was made clear in the June session, the QHIO program has not achieved statewide exchange network for event notification, despite being required to do so. I think establishing QHIO to QHO standards will certainly help with that, but it's not going to solve the broader trust, competitive, and business challenges that were talked about last time, and I think we have certainly seen out in the market that have really kind of prevented the QHOs from working together to meet their obligations to share ADTs with one another. And just one other thing I wanted to mention in regards to TEFCA and national networks. First, TEFCA does actually do more than query. They support push-based exchange. There's a lot of transactions for electronic case reporting that are pushed over TEFCA today, and similarly over Care Quality eHealth Exchange, some of the other networks. And then just from a reciprocity perspective, I do think it's important to keep in mind, these national networks like Care Quality that, exchanges more than 1 billion transactions a month for, query-based exchange and very specific purposes. Like, they have successfully showed that kind of a reciprocity, no charging approach has worked at scale nationally. So thank you.
Thank you. Okay, I think we have one more comment in the room, and then we'll go to a short break.
Just piggybacking on that, from a national exchange perspective, there are limitations, and the limitations do not support rural. There's geofencing that happens on national networks. There's geofencing that happens on TEFCA. There are issues with the national networks that QHIOs can overcome, and we do overcome with sharing with data with one another. Also, patient matching. patient matching on the national networks, every endpoint is in control of that patient matching, and that creates problems. So there are barriers for us to get data over the national networks that we can, as QHIOs, work amongst ourselves to solve those issues and to have more efficient data flow. So I did want to bring that up. Thank you.
Great, thank you. Okay, are we good on the line? Any other public comment on the line?
No more.
Okay, excellent. Well, thank you, Jacob. I know we have a to be continued, but our fearless leader here is going to tell us we have a break.
Yes, we are going to take a 10-minute break. So coming back right at 2 o'clock, promptly at 2 o'clock. Don't make me do a countdown again. But I want you guys to get up and stretch. I'm in the post-lunch slump, and sitting is the new smoking, so I don't be responsible for your bad health. So get up, stretch a little bit, and come back at 2.
On the car seats and strollers, you know what we put at this time.
We have some important stuff this afternoon. So everyone has their coffee, their water, and we're gonna wait. I think pretty much everyone's here. Okay, back to you. Maybe yours wasn't on.
Mark, can you hear us now?
Absolutely. Thank you.
Okay, great. Thank you.
Okay, I think I'm up. And just to summarize for those online, we have more good stuff to talk about here in these last couple hours. So we are going to continue the conversation of the QHO program evolution. Excuse me, let's go to the next slide. So in this section, we have the opportunity rather to dive into specific potential solutions we might consider for our program. So let's go to the next slide. Just to kind of summarize here, there are 6 problem areas that we identified for this program. We've talked about 2 planned actions that HCI intends to take to start addressing some of these problems, but they don't address all of them, and they don't address all of them completely. And so we're now going to talk about 3 potential solutions, those circled in the right-hand side with a yellow box that we might consider for this program. And then at the very end, we'll open it up for other potential solutions we might consider. As a reminder, in October, the goal is to refine these solutions enough to bring them to a vote. So we want to get as close towards refined solutions as we can today. There's 3 solutions I'm going to bring up for discussion. Those being a minimum operating threshold for the program, allowing QHIOs to specialize, and requiring the use of QHIOs in certain circumstances. So let's go to the next slide. We're first going to talk about the first 2 solutions. I'll allow for questions as we go, but I'll just ask any discussion in terms of support or disagreement with that solution, just hold, because we will have, after we talk about the first 2 solutions, we'll have a space for discussion. So any questions are welcome as I go though. So again, let's jump into the first solution. This is requiring a minimum operating threshold. So this potential solution requires the QHIOs demonstrate a minimum volume of existing business in order to qualify for a specific exchange type. This requirement would ensure that QHIOs have made the necessary investments to deliver services at scale and have a track records of meeting the needs of participants for that exchange type. Now, a minimum operating threshold would mean that participating HIOs would have to have shown strong evidence of capability, and it would reduce some imbalance we're seeing today in terms of exchange between the QHIOs. However, this solution could make it more difficult for smaller startup organizations to qualify, and it's also possible that some current QHIOs could fail to meet the minimum that we set and likely not qualify for that exchange type. Let's go to the next slide. Now, introducing a requirement like this would be an update to our QHIO program with a likely rebid or reapplication process, and may require periodic requalification or even establishing a qualification term. This approach does align well with what other states have done, including Massachusetts, who have required that HIOs participating in their statewide network contract with at least 20 acute care hospitals in order to apply. That is not to say that that would be our minimum operating threshold, but that is a state minimum operating threshold that exists. And this approach also allows for a model where an intermediary or a business associate can pay to receive data for which they cannot reciprocate. We are going to have time to discuss, just a reminder, but I'll pause for any questions on this solution, this potential solution. Hearing none, we will jump to the next solution. As a reminder, I'm going to talk about 2, and then you guys will have the floor. So the next solution is allowing QHOs to specialize. That is, we would identify QHIOs that are qualified for each exchange type. For instance, an organization could seek qualification for event notification, or they could seek qualification for request for information or information delivery, or two or all three of those exchange types. This approach would help address some of the sustainability concerns that QHOs have raised, as they would only need to make investments in areas that are already in their current portfolio of service offerings. It would also address some of the reciprocity issues, as each QHIOs working within that exchange type would have more equitable investment from their partners who are specialized for that type. This approach offers participants better understandings of the services that each QHIO offers and how those services might align with their needs. In terms of pros, as I mentioned, this allows the QHIOs more flexibility, allowing them to identify services that align with their business model. And in terms of cons, it is possible that only a few QHIOs will seek to be qualified for all exchange types, which means there is limited assistance for organizations who are looking to contract with one organization to meet all of their requirements and their needs. Some participants might need to switch from their current QHIO and or use services from multiple QHIOs to meet their requirements. Let's go to the next slide. As with minimum operating threshold, this solution could be implemented with revisions to the QHIO program. It would also likely need to come with a rebid or a reapplication process with new application criteria. It would also require QHIOs to identify the exchange type for which they would like to seek qualification. Now, this is consistent with what we're seeing in other states, including Maryland, Massachusetts, and New York. And while it is a shift in approach, we think it is achievable with relatively modest effort, and its gains at least outweigh the effort required to implement. Now, we expect this to create a more equitable QHIO program and a potential opportunity for other intermediaries to begin participating. With that, I will open it up for questions first on that, and then we'll go to the discussion.
Okay, first let's just take questions from the committee if you have any. Mark, do you have a question or a comment? Well, either way, we can start with you because we don't have any other questions in the room. So
Thanks. I raised my hand on the prior one for the minimum operating threshold. And keeping it at just sort of clarifying question level for now, on the current state, you mentioned QHIO standards, and then what we're discussing now is what I take as one possible minimum standard, which is minimum operating threshold. I'm wondering if any other minimum standards besides just that minimum operating threshold was considered.
Yeah, I think when we get to the discussion, which I think we're heading into, we'd welcome any feedback you have, Mark, on items and areas for us to consider. We'll say that we focused specifically on one that was addressing the reciprocity concern. That was an area of focus in the last meeting, but we welcome other areas.
And I don't know, tell me if this is, my interpretation of this is also that when this group did the look at what are some of the systemic barriers and like what needs to be addressed to set up a more thriving and productive sort of network of QHIOs or system, these were the pieces, the standards of like implementing consistent standards. It feels like you guys have, like we've talked a lot about that. You said that's a move that you are making in some domains. And so I guess this is really more with the intent of like setting up a functional QHIO like relational system. Is that correct? Okay. As opposed to like setting a standard per se. I mean, I don't know, Rim, if that's what you wanted to say, but just try to understand the nuance there.
I guess I have a question for you, Mark. Are you asking about this in relationship to what Jacob shared before the break as establishing standards? And if so, there we're talking about technical standards and not standards of operation, which this might better align with.
Okay, well, I appreciate that. That's if we're categorizing these as operational standards, that's a helpful set to know that that's what we're dealing with. Thank you.
Great. Okay, we're going to go in the room to just comments and feedback. So Andrew, you're up.
It's more a question on the specialization to get the department's thinking. I don't have a form thought on either of these in terms of preferences or point of view yet. So, but in terms of the specialization, would that be the, I guess, categories of specialization so that you have that we don't have sort of a land rush to go do, I don't know, just event notifications. And then we don't have Q Ohio's doing the other pieces of it. Have you guys thought about like sort of limitations or structure around those categories, or is it still sort of business plan dependent upon the Q Ohio and what the market might need? Again, I don't have a dog in the hunt on it, just curious thinking.
I think it's largely the latter, seeing what the market needs and requires and wishes to pursue. But just to say, the minimum structure we've defined is by exchange type. So organizations might specialize specifically in event notification, requests for information, or information delivery, that being orders and referrals. And so that would be the kind of starting parameters for a solution like this, and how we might push or encourage organizations to entertain one or more of those options. I think still worth considering and exploring. I have a related question, then I'm going to go to Aaron. But when you talked about in the specialization category, so basically there's more flexibility for QHIOs to specialize and do certain data types. Can you speak to what that looks like on the provider side and the community organization side, which is, because that's, I think, somewhat what we're grounding the goals of, DxF and the health improvements that result in. So what does that mean for them?
I was going to sit back in the back of the room so I didn't have to answer the hard questions. I think that's a really good question. I think one of the things, Jacob talked about the two goals of the QHIO program, and one of them was to meet the needs of providers. And the idea that I could find an intermediary that would meet all of my needs was always one of the things that we were thinking about. We do need to keep that in mind as we think about specialization, and do we put that at risk? That said, I know a smaller state, but if we think about Massachusetts took that to the extreme, and they have two vendors that provide event notification, and that's all they do. And then they have a multiplicity of vendors that do direct messaging, and that's all they do. And so they took that to the extreme, and it is serving the state well despite that. Now, I don't think that we would seek to go there. What we're seeking instead is to allow each of the QHIOs to say, well, this is the business I want to be in, so that's what I'm going to seek to qualify in. And with the hope and, quite frankly, the expectation that some of the QHOs would seek to qualify in all, but something that we'd still have to take a look at. I don't know if that gets to the answer to your question or not.
No, that's helpful. I guess I just was thinking, because you're trying to solve for how to make it work. And I'm like, one way to make it work is let everyone do the thing they're good at. And then it's just like, what are the downstream effects of that, which sound like they are that now as a primary care provider, I got to connect to 5 QHIOs to get my full data set. The other way you do it is you get a little smaller and you're a little more consistent on your standards. And so that's harder for QHIOs. But then so it's like you're kind of pulling at different ends of
I think
spectrum.
So. The one thing that I would say is that what wasn't said with any of this is that if I do specialize in exchange, I have to talk to the other QHIOs that also specialize in that exchange method. So that at least if I am looking for event notification, I don't need to qualify. I don't need to contract with all of the vendors that are all of the QHIOs that are doing event notification. Again, like Massachusetts doesn't, by requiring the QHIOs to exchange that data type with each other. And that becomes part of the do I want to be qualified in this comes with the requirement. If I do, I must exchange data with all of the other QHOs that likewise.
So the factor of the multiplier is the types of data, like however you decide to divide up the specializations. Okay, great. Aaron.
Just following up on that conversation, I understand the effort here to allow for the specialization because that's sort of what's happened in the beginning of setting up this network, and it lets the QHIOs operate in the area where they're best at and can serve the customers. Messaging wise, though, the message has been sign up with the QHIO. It's all you need to be compliant. That is the message that's been clearly delivered. And I think I see a future where branding is going to be a problem, where if we're specialized, we can no longer use the QHIO name anymore. That's already been out there as like one-stop shop. And now you're going to be QHIO, but it's only ADT. That's going to be really hard to communicate down to the provider level. All they're going to hear is QHIO. And it's going to be really, really hard to say, well, you actually need 3 QHIOs now. It kind of doesn't make sense when you say it that way.
It's great feedback, Aaron. Thanks.
All right, Mark, we have you online.
I'm sort of thinking about this question with another possibility, which is sort of use case. Are there use cases, common use cases that will depend on different areas of QHIO specialization, and to maybe go to an extreme to try to illustrate? This is more of a question. What do you think? Do you think that's specialization is a problem when you're organizing your work by use case? A very elaborate use case might be shared care planning, where you're coordinating among a lot of different providers. You're both getting information in from a lot of providers and payers and CBOs and social service organizations. You're sending out to all of the people on the care team in all of the different walks of life. Does that specialization mean that you've now got to build in multiple QHIOs in order to meet a single use case? And of course, people are not just doing one use case. They have, as they're providing care, a variety of different use cases arise. I just picked one to try to present a hard case for purposes of understanding. Thank you.
Thanks, Mark. Ali.
I hope there's an answer there.
The answer is it's excellent feedback, and we'll take it back. Thanks, Mark.
Thanks for sharing this potential solutions and opportunity to talk about it. So the 2 questions regarding the specialized QHIO, which I think could be a problem. One problem is the fragmentation of all this data. The other problem is that are we going to use the same threshold, operational threshold for this specialized, or is it going to be a different type of threshold? And the other question related to that is that if one specializes its messaging, and then another QHIO has a ton of data that then they have to work with this smaller specialized QHIO that only is specialized, that's kind of an imbalance of the data sharing. I think that's the problem right now we have with respect to trust that you mentioned earlier. The QHIOs, not everybody has all types of data, behavioral data, social services type of data. So that's a challenge right now. But having said that, I just want to make sure that everybody understands. Right now, QHIOs are exchanging data with each other. So Lanes is exchanging data with San Diego, Sac Valley MedShare. We are in process working with MX. We actually worked with MX, but then they changed their method to different methods. So we are working with them to address that. So the QHIOs are working together right now. I think the problem is that there is a lack of trust. There is a lack of imbalance between the type of data that one has and the other one doesn't have. And it's all for the benefit of the providers and the patients, which is great. But in terms of sustainability and then growing from there, that's where I think this group needs to address in terms of how can we strengthen the current infrastructure that's in place to take it to the next level. I think that should be the conversation rather than bringing in other parties and create more fragmentation, create more distrust, I would say. Thank you.
Great, thanks, Ali. Let's see. Oh, sorry, Ram.
Just a couple of things real quick. Ali, I think that one of the things that you bring up points out why we wanted to talk about these two potential solutions together. Is that it's not clear that you can talk about specialization without talking about minimum operating thresholds. How do you specialize in something that you're not in business in today? And so I would encourage people to think about these two together. Do they make sense individually or do they make sense together only is one of our questions. And then, Ali, I think that you really centered in on one of the things that we continue to talk about. We gave it the term reciprocity, but having valuable data, inequities in the valuable data that we have to exchange among QHIOs. Do these potential solutions start to get to that or not? Is one of the questions that we're really trying to discuss today. And if this isn't going to solve that, then we need to do something different. But if this will start to get there and there is a path, then maybe it's something to consider. So that's just kind of the context of thinking about these.
Yeah. And I was just going to add, I think once we get through this section and then the second section, I mean, the question is, because what I would say back to you, Ali, in your comment is like, so what should happen? And I don't want you to answer that right now, but like there is a time that we want to hear. I mean, that's the goal, is to hear those things. And you have a great vantage point. Okay. So Kieran.
I think some of the comments about just concern about additional fragmentation and many more QHIOs for providers were certainly on my mind. Although I think there is probably a difference between specializing in functions of data exchange versus what was raised earlier about like clinics need a specific data set and don't need all of these other things. So just wondering if there's some sort of middle ground here where it's like there's some basic functionality that everyone has. And on top of that, there's some specialization that maybe would be helpful. But the question I had was around the minimum operating thresholds, just if we know anything about what types of providers are using what size of QHIOs right now. Like, are all the independent physicians using a small QHIO? I just feel like that would be important information to that, to sort of, evaluating that proposal.
Did you want to add, do you want to go to her, talk to Kieran? Oh, yeah. Well, you answer it if you know. Tell us what you know. Give her some insights.
Some insight on that is that, no, I think the QHIOs as a regional work with all types of care providers. So the small practices, solo practices, to large hospitals, to counties. So variety of the care providers. So we don't have, in fact, all the nonprofit QHIOs have a broad range of providers, the small to large.
Okay, so I am hearing, like, for a follow-up from Kieran, this kind of concept of like, are there some demographic differences of like the either organizations that are served by or data types kind of thing?
It's kind of like if you were to say, okay, all small QHIOs, you don't qualify anymore.
Like, what impact does that have? Yeah. Okay, great.
Can I add something? So there are 3 for-profit QHIOs also in the mix that they don't have as many as provided. They don't have many providers, small or large, actually.
There's more health plan data at some may have more health plan clients versus more provider clients.
Profits.
Is that what you're saying? Yeah. Okay. Great. Colleen.
Thank you. Most of what I wanted to say has been already said, but I just want to maybe underscore a few points.
I do think that these two together are really important, the minimum operating thresholds and the specialization. But it's hard to be supportive of specialization without knowing more about the minimum operating thresholds. And I really appreciated Dr. Sales' mentioning of the impact on providers or organizations, because I think that the orientation is on the slide around the QHIO impacts. But providers, whether they're complex organizations, county health departments like mine, or small organizations or CBOs, I think it's going to be very difficult for them to figure out what bits and pieces they're going to need to cobble together to cover various requirements, and also the use cases that Mark referenced. I think it could be very well that you're going along thinking you've got everything covered, and it turns out that that's not true, and it really is highly dependent on the operating threshold and how the specialization is accomplished. So I just wanted to underscore those few points.
Wonderful, thank you. Yvonne.
Thank you. I think it would be helpful at some point to have a layout of the current landscape QHIS. I feel like we're sort of talking in a little bit in the abstract about, and I think the folks who are very intimately involved in this all the time probably know it off the top of their head, but I feel like I have like this like spreadsheet in my head trying to like, wait, who does what now? So I think that would be helpful, I think, for the October discussion to have that laid out for us, the existing market and who's doing what. I don't think any of that is proprietary. I mean, I think that's all public information, right? So, okay. And then on these two solutions, I think from what I've kind of heard, I think that there is a sense that the world has changed and we need to do kind of a review of what we had previously required of QHIOs and what the world needs now. I think it's very hard to kind of look at two solutions kind of in a vacuum, because it's kind of like, are these the only two things we would change? Because it sounds like from the conversation, there are potentially other things we would change too. I mean, these might be two additional things kind of on the menu of things, but I think we kind of have to look at it as a whole, because to your point, I think there is a lot of dependency of like, you change this one thing, well, then what does it do, to this other factor? So I think that would be helpful. And I would also appreciate some information around like, what is the cost to the providers in all of this, right? Because we can set rules and changes. And I think for some providers too, they are at the mercy to some extent of their vendors, right? And how the vendors are going to respond to that. And so it's hard at a provider level, unless you are a provider who is directly connecting, and it sounds like some are, some aren't. That's a piece, though I feel like there are potentially some unintended consequences around cost as well, is, are you paying per transaction? And if somebody is specializing, do they increase the cost of their, per transaction there because they don't have this other set of exchanges that they do. So that piece of it, I have some concerns about as well.
Thank you. Julie. I was just going to say, you should stand up if you want. Oh, you got to get your mic. I was going to say, folks, feel free to, what is it? Sitting is the new smoking, as Athena said. So feel free to roam and stand up. Just come back to your mic if you want to talk.
I appreciate what Yvonne just said. I do want us to think about the unintended consequences. So 5 years from now, we're not looking at decisions we made today the same way we just had the previous conversation, which is it evolved. It's what we have. That's what we need to make better, rather than thinking about, changing things pretty dramatically by looking at very different systems that you talk through from New York and Michigan and Maryland, et cetera. And so for me, the minimum operating threshold and the specialization and implications for what that might mean for social services when we decide to really focus on adding them in. Many of them are not in, they can't afford it. They're smaller than the small private practices. And if we look at the CIE, they all are in there, right? And so what is it about the CIE that's working for our community, the social service community, that we can think about as possible solutions to add in here, or just poke at whatever we're thinking about through that lens And maybe it's asking other folks, because I don't have that level of experience, but folks like the folks at the SHE and at 211 to poke at whatever we're doing and saying, in 5 years from now, when we are looking at adding social services, will a minimum operating threshold that doesn't include social services do what we needed to do to bring social services in? Or does the specialization that they've all built up for the last 5 years not meet when we need to bring in social services? So I just want us to like keep on holding so that we're not in that same place 5 years from now that we are now in terms of that earlier conversation we had. Thank you.
Thanks, Julie. Aaron.
Sorry, I just wanted to add to the concern around the experience for the providers and the costs if now we're going to have to contract and also do separate projects. I think about the time involved for onboarding a vendor or a QHIO. And that's going to be very concerning, I think, for a lot of the health centers that we deal with on a regular basis. But I think back to the previous committee, and I think what we're saying here is maybe we missed the target a little bit in the previous committee, which I was on. So it means I was a part of missing the target, right? And if that's the case, I think the original intent was the QHIO would offer all the services. That was the intent. And now we're trying to address that, but maybe go back to what the original intent was. And we have to like reinforce the original intent, which means to lean harder into the QHIO must offer all services and try to solve for that problem. And instead of maybe doing something different, what we're talking about now.
That's great. Thanks, Aaron. I don't know if anyone on the team wants to provide any context to that, or you want to do that another time. Like the history part of why it was designed that way.
Yeah, no, I think the program was designed exactly how you said, Aaron, where there were a robust number of requirements across a number of different exchange types, a number of different things, with the explicit goal of helping meet all DxF participants' requirements. And the reality that we've seen over the last several years is that most of the QHAOs have not been able to meet all of the different requirements across all exchange types for all types of data. And asking them to do that has led to a number of different sustainability concerns that we shared in the last meeting. And so the question is, if we do continue to push down that route, we look towards maybe just minimum operating threshold in the absence of something like specialization. Are there QHAOs who are still able to meet those requirements, the robust requirements of helping all participants meet all their requirements? And we, I think it's worth an investigation. And the answer so far has been not many.
Just to clarify, sorry, when you say not many can do everything, I'm sorry.
Not many have been able to meet all requirements of the QHAO program, which were robust from the beginning to try to meet all participants' requirements.
Okay. And is there some concern that, trying to figure out how to say this in the right way here, but is there concern that a smaller number of QHIOs that can do everything, that would not serve the needs of the entire state?
I think it's, we welcome feedback like that. And I think that's okay. What we're looking for.
Yeah. And would you say, because I think then it sort of begs the question, like why is what you say true? And is it because the original intent is like Aaron said, something was missed? That wasn't a suboptimal design? Or is it that there's some other conditions that are creating the lack of ability to kind of get there? And I feel like that, I know we've done some of that in the barrier discussion. I'm just wondering, because you could imagine if folks felt like they had sustainable business models and appropriate geography, maybe they could do all the things. It would be interesting to think about, are there sort of different scenarios that we should test together as opposed to everything in isolation might be one thing. It's sort of a trend I'm hearing from, or theme I'm hearing from folks.
Yeah, and I would say it wasn't, I don't think anything was missed. From the committee's perspective, but we then invited people to sign up for the program, and there just was apparently the people who signed up could not commit to what the intention was. And now we're trying to solve for that. I think I would just say again, I think the ultimate best case are QHIOs that can service the entire state with all the services. And if that maybe is a smaller subset, maybe that's how it is in the current state.
Got it. Thank you, Erin. Lynette.
So maybe a few kind of random thoughts on these topics. I mean, one, I like the idea of the minimum operating threshold, in particular from the perspective of no attestations, prove it. So prove that you can do something, you meet those thresholds, you get to be a Q. There's lots of entities in business that are not Qs, but what is special about being a Q? And so having to be able to prove that, doing that on an annual basis, everything from fiscal to actual capabilities of exchange. One of the things that we've been trying to figure out how to accomplish for a few years from the Medicaid perspective is how to bring in federal funds. And with that comes a lot of accountability in terms of how many Medi-Cal members are being served. How do we make sure we're paying our current share, not somebody else's share? So those things require numbers, they require reporting, they require keeping those things up to date. So the opportunity for an organization to become a Q or to not maintain a Q on any annual basis, I think makes a lot of sense. And so from the minimum operating threshold perspective, that would give some of those aspects a lot more credibility around putting the monetary investment in play. Knowing because when we go to CMS and try to justify the federal funds, we have to answer all those questions. So I would love the QHIO program to help me answer all those questions. A little bit of selfishness there. In terms of the specialization piece, it's really, there's a lot of different pieces. So, I don't really have a strong feeling one way or the other. Are there a set that particularly specialize in notifications, doing push-pull queries? Are there some that actually do the full population health services component to it? I don't think everybody needs to do all of those things. Some may make a special business in the population health piece. And that's something, as I talked about earlier, we've actually already built out in the Medi-Cal space with our Medi-Cal Connect. So that's not something we need, but notifications and delivery of clinical data absolutely is on the list of what we need. So how do you so that specialization, I don't know if it's specialization or if it's from the menu of set products that are needed, because that also then figures into cost. If I'm paying for the cost of notifications and clinical data delivery, I would expect that to cost differently than if I'm paying for notifications, clinical care delivery, and a population health management focus that helps me do my quality measures. Those are two different sets of things, right? So to the extent that there's an aspect of specializations that figures into cost, there may be an aspect to think about there. And then the other aspect, just knowing that there's organizations that maybe what they do is they specialize in a particular market because there's unique things about that market. EHR vendors certainly have done that. There's certain markets that are supported by particular EHRs as opposed to others. So I think that's one of those that would be great to have more discussion around and sort of think through what that looks like. But I just wanted to do a yes, please, for the minimum operating thresholds.
Great. No, thank you. Yeah. And that theme, I'm sort of tying that back to Colleen's comment around having a core. I think, there seems to be some standard that DxF is built around that the group designed to. And then you're talking about, and there's other types of services that are high value potentially. Is that the specialization? Is that the sort of on top piece, or is it part of the core data components? So that's a good kind of thing for you all to be thinking, I guess. Okay. Who? Oh, hi, Lucy.
Hi. So I wanted just to echo Dr. Scott's feedback around the minimum operating threshold. I think one thing that when we do go down that route, we really need to incorporate the end user feedback, because we can't just say, yay, you met the minimum threshold for whatever event notification. What is an event notification, and what does the success mean? And so I think we need to make sure that we're bringing in health centers, the end users into this conversation to make sure that we're feeding off of what they see as a successful event notification. So I think that that's something that I really want to echo here, that yes, the minimum operating threshold, but really making sure that we're understanding from the experience from the end user. Their voice is very important.
Yeah, I guess I think David is one of our key representatives of end users. I mean, Lucy, you obviously as well, and Bill, maybe to an extent. Yeah. I don't know if you have comments, but okay, he's done. I think that's it. Is there anyone? Oh, no, it's not. Andrew.
Yeah, we, as a health plan, we collect them through our QHIO partners. We collect them directly from the facilities and point-to-point connection. So there's utility in having some sort of centralization around that, because it is a hunt and peck approach that happens today, basically. So as an end user of that data as well, right? So we have legal obligations and program participation requirements to depend on us getting that in.
Yes, we should not discount the plan end users. Yes, that's helpful. Okay, I think we are going to move to public comment. Do we have any public comment in the room on this topic specifically? Hello.
Hello, Felix Su with Manifest Medics, again, statewide nonprofit QHIO. We on minimum operating thresholds are quite supportive. Requiring QHIOs to demonstrate a real verifiable base of business before qualifying for an exchange type is a real reasonable way to ensure that the designation means something. That said, how and where you set the threshold obviously matters, as was alluded to by some of the comments during the committee discussion. If you set it too low, as in the case of ADT notifications, where the logical metric would be the number of hospitals that are on each QHIO's network. By way of example, in Massachusetts, I think it was cited on the slide that the minimum threshold would be 20 hospitals. Well, here, as the QHIO in California, we have well over 140 hospitals on our network at this point. So there would still be a very vast imbalance between the ADTs being shared between our networks and even others that can meet that threshold in that hypothetical example. Therefore, it's still paramount to allow for much larger QHIOs to recover their costs in that type of exchange when the volume coming back is far above what the other network can reciprocate. We've proposed that this be addressed through an interchange fee structure or proposal, which we have written up in a document for HCI, and that we're also happy to leave behind for committee members to review as they're interested. Secondly, on allowing QHIOs to specialize by exchange type, we have some real reservations. If you go back to just the two stated goals of the QHIO program, it's to support statewide exchange and to help participants meet their DxF requirements. It is not to prop up existing QHIO's business models. It is not to ensure financial sustainability of any particular QHIO. And as many of the committee members have very eloquently pointed out, having a QHIO that can pick and choose what type of exchange it offers creates a really serious fragmentation. Participants today already struggle to navigate the DxF, asking them to contract with multiple QHIOs for different transactions adds to complexity. And really, at the end of the day, QHIO should be expected to meaningfully support all exchange types that are required under the framework for all types of participants, much closer to a health data utility model that's being pursued in other states and across the country, and not specialize their way around gaps. Thank you.
Thank you, Felix. Okay, on the line, Akira, do we have a public comment on the line?
Yes, we do. Corey, you can unmute now.
Great, thank you. Corey Mertz again from Point Click Care. We're supportive of allowing QHIO specialization and setting minimum operating thresholds. I think both these align with national trends we're seeing. I think, allowing the specialization will also allow providers more options. They'll be able to pick and choose. I think as you see today, sometimes providers, EHR vendors are supporting some of their DxF needs, maybe not all, but this sort of specialization model would make it easier for a provider to pick and choose the services they need. Otherwise, today they're potentially paying both their EHR vendor to do something and a QHIO to do something. Whereas this kind of specialization model could eliminate some of those things. Two examples to maybe look at here. New York, I know, has already been on the table, but obviously they have had their kind of core services, value-added services for many years, and now they're moving towards more of that specialization model. But if you are kind of exploring that, definitely value in looking at their kind of journey over many years. The other one I would encourage you to look at when you think about specialization is the ONC Health IT certification program, which in the early days really started with kind of this idea of, hey, here's a full EHR certification. If somebody meets this, then a provider can go and buy it and meet all their obligations from a kind of a meaningful use perspective. Well, over time, the federal government kind of saw that as a limiting innovation. So they have moved to the modular certification program that exists today. And I think that has worked pretty well for the provider community and hasn't necessarily run into some of the concerns that you would expect, right? Where it was easier to kind of buy that full suite. The last thing I would just say, as you are kind of considering big changes to the QHIO program, like adding specialization or setting minimum operating thresholds, we think it's going to be really important to reopen competition so entities can apply and kind of go through this process with the new set of rules. Thank you.
Thank you. Okay, back in the room. If we can try to keep to 2 minutes, we would appreciate it. Thank you.
Sorry to interrupt. Do you mind just turning your mic on? It's the button at the bottom. Sorry, it's turned off in between.
Okay. There you go. Robert Denson, supporting San Diego Health Connect, and I'll try and keep it under a minute and a half. So a couple comments and one question for clarification. So thank you for the opportunity to be here on behalf of HCI and San Diego Health Connect. I just want to reiterate, and I think Jonathan mentioned on the call, California, I think, is well above and beyond many states at this point in time in the world of exchange across communities. From my understanding, we're exchanging millions of data points and millions of query and retrieve cross-community information sharing, which isn't happening at scale from anywhere that I'm aware of. And my experience does across many states as well as internationally. So with that being said, too, San Diego Health Connect today shares data with Health Gorilla, Manifest, MedX, Lanes, and also Sac Valley MedShare. So we're supporting quite a bit of health data sharing. The other piece too, we do support minimum operating thresholds from a technical standpoint. I think that's really key. I think it's important to sustain the program and build it up. I do caution a little bit about like FHIR as being the base. I think that's going to create some investment. And so I would caution about starting that. I think that's great aspirational. But while we're ready to support it today, I think a lot of communities will struggle. I've seen it across many communities globally. The last piece is I heard a number of comments around Massachusetts being one of the examples and a specialization around direct messaging. I don't believe that's one of the requirements of a QHIO today. And so I'm just wondering, are you trying to expand the services at QHIO? So I think clarifying that would be really important as we move forward too, because it sounds like maybe you're using other examples that aren't in our QHIO requirements today. Thank you.
Thank you. Hear anyone on the line?
No hands raised at this time.
Okay. Well, Athena is going to lead this committee through a fun exercise, which I'll invite people to, if you feel like it, you can stand up for it, but you do not have to.
You
All right.
could stand up. There's no pressure. Okay, so we're going to test your ability to listen. So fair warning, we got to pay attention here for a minute. We're going to do kind of a exercise here. This is not a formal vote of the committee, but we are going to ask all voting members to participate in this activity. And so just start by taking your hand, putting it up with a fist. Okay, good. Folks on the line, you're going to have to show us in your camera. So kind of, next to your face. Okay, so what we're going to do here, we're going to do this 3 times. So this is our first one. So everyone just open and close your hand. Get those fingers ready. All right, here we go. Here's the yoga teacher and me is going to come out. So, non-voting members too. Oh, everyone gets to participate. Okay, are we allowed to do that, Courtney? I'm looking at the attorney. The attorney says it's a poll, not a vote. It's not a formal vote. It's going to be considered. Okay, everybody gets to do it. Okay. All right. Okay, you don't have to, but we're going to record it anyways. We're inviting you to participate. So, okay. So let's go ahead and see. The first question is about requiring minimum operating threshold. So we're going to do each one separately. So you have a closed fist. That means I don't support this at all. I have strong reservations. You guys can read 1 through 5. Right? So 5 is like, I love this. Let's go and do this. You're going to have to hold it up until I call on you and record your vote. So you may have to hold up. So you're going to have to freeze. And we're all going to do it at the exact same time. So you're not influenced by your colleagues. So I'm going to do a countdown. See, this is fun. We do this in the afternoon to get your blood pressure up and, get you moving. Okay, so ready? So I'm going to count down from 3. When I get to 0, you guys are going to vote and then hold your vote. Do not change it. If you change it, you're going to be in trouble. Okay, ready? Just kidding. Okay, so we're going to count down from 3, 2, 1, vote. Okay, now I'm going to call on folks and we're going to record what you have. So Joan's a 4. Bill's a 5. You're holding up 4. Are you a 4 or a 5? You want to be a 4? You could be. Okay. Bill is a 5. Colleen is a 5. Yvonne, a 3. David's not here. Aaron, 5. Katie, 4. Andrew, 5. Scott is no longer with us. Ollie, 5. Eric on the internet there. 4? Yes. Okay. He's saying 4. Okay. Lucy, 4. Mark there online.
1.
1. Okay. Kieran, 3. Dr. Sales, 4. Julie, 3. And Lee is not with us. And then we're going to go to our ex officio members. Rebecca, are you still with us online? Okay, we'll come back to Rebecca. Amanda, a 4. Jana is no longer with us. Taylor, we have Charles online as a 4. Is that right, Charles?
Yep.
Okay, Charles is a 4. Shannon, 4. Lynette, 5. And Jared, 4. Okay, did I miss anybody? Anybody in the room that I missed? I see all the fists are down. Okay, anybody online that I missed? Nope. Okay, great.
Dr.
We
Thomas,
are
I'm a
done
4.
with. Oh, thank you. Okay, great. All right, we're going to go on to the next one. So now you know what we're doing. We've done the, when we will go ahead and, I guess we have to summarize those. So I don't know if we have the totals over there. Heather, do you have the totals? So how many zeros? 0 zeros. How many ones? 1 1. Live polling. 0 2s. 3 3s. 9 4s. And 6 5s. All right. There we go. Round 1. Give yourselves a round of applause. Good job. You did it. Okay. Now we're going to move to the second potential solution that we discussed, which is allowing, yes, please. Yes, we are.
Not a vote. Who
Not a
polled
vote.
what?
Not a vote, just a poll.
Very clear.
How people express. Yes, thank
Yes,
you.
thank you.
Yes. Yes. Okay, so we're going to do it again. So get your fists ready. This time we're going to count down to 3 and we're going to vote on allowing QHIOs to specialize. So we're going to do 3, 2, 1, 0, vote. Okay, and this time I will go from the bottom up just for fun. Let's see. So Julie, a 0. Dr. Sales, I can't, a 1. Kieran, a 1. Mark,
1.
1. Lucy, 4. Eric is a 2. Is that right, Eric? Yep. Okay. Eric's a 2. Ollie, a 1. Scott's not with us. Andrew, 1. Katie, 2. Aaron, 1. David's not with us. Yvonne, 2. Colleen, 1. Bill, 3. And Joan. Okay, and then we'll go through our ex officio. Rebecca, have you joined us? Okay. Amanda, 3. Jana is no longer. Charles, you have a 2 there, Charles? All
Yep.
right. Shannon, 2. Lynette, 3. And Jared, 1. All right. Did I miss anybody in the room? No. Anybody online?
2.
Okay. 2 for Brian. Okay. Jennifer, Dr. Sales was a 1. And Mark, you were a 1 or a 2?
I was a 1.
You were a 1. Okay. Thank you. Okay. So we're going to quickly summarize those votes. So how many, let's start at the top this time. How many 5s did we have? 0 5s. How many 4s? 1 4. How many 3s? 3 3s. How many 4 or how many 2s? 5 2s. And how many 1s? 7. And how many 0s? 1. Okay. We did it. We were able to get through the voting.
All right. Just a quick point of clarification. This is for members only, so please only keep track of the actual members. Brian, we appreciate you're here, but this is actually for the members of the advisory committee. Thank you.
Okay. We're going to go ahead and keep on moving on then. And we're going to come up with some additional solutions. I'm going to hand it back to Jacob, I believe.
Okay, we have one more solution to talk about today. This has been great, folks, and I'm really looking forward to October. But we have one more solution to talk about here before we close out the day. We got a lot, we got some homework to do, but that's a great thing. That's what we're here for. Okay, so this last solution is requiring participant use of QHO services in select circumstances. And so what this might look like is, as an example, with event notification, it could look like requiring every hospital to work with the QHAO to share their notifications of admissions and discharges. In contrast, we might not require the use of a QHAO for other exchange types like requests for information, as the nationwide networks do provide some strong support for connected query exchange. We believe this is a solution that would minimize fragmentation and create greater efficiencies in exchange. It would support QHO sustainability, as it would provide a more reliable customer base and revenue stream. It would also address a number of the challenges we talked about with voluntary adoption in those many different point-to-point connections between organizations. This approach participants could also avoid the need to have to contract with multiple intermediaries in an effort to obtain statewide coverage, and a single connection would ensure statewide coverage. This approach, however, may require some participants to start contracting with a QHAO that haven't chosen to do so today, and it might limit choice for some exchange types. So as an example, today, only 55% of acute care hospitals currently use a QHO to deliver their event notifications. Let's go to the next slide. This solution may require legislative change as well as a new application cycle to create opportunities for other intermediaries to participate. It may also require establishing pricing guidelines in the program. In terms of event notification, this approach does align with prior stakeholder feedback and would enable statewide exchange through a single QHO, reducing cost and complexity. It does align with many of the trends we've seen in other states. I think Rim highlighted it earlier. California is not unusual in many things, but it is unusual in that we do not require the use of our designated intermediaries. And so it does align with North Carolina and Maryland and Massachusetts and others. It's also similar to the nation's TEFCA network that requires the use of a QHIN. But while TEFCA requires the use of a QHIN for everything, we certainly don't anticipate requiring the use of a QHAO for all exchange types nor for all participants. Now, this type of solution would require some time to implement as it likely needs a legislative change to accomplish, but it does provide a clear path to breaking down silos that exist today in the industry. And we believe that it aligns with the wishes of some stakeholders who wish to have one connection to access the data they need across the state. So with that, that was a quick one. We'll first open for questions, clarifying questions on that, and then we're going to open it up for discussion, and we'll do a 5 poll again on the solution. But questions?
Thanks. I did have a question, just clarifying when you're kind of envisioning. So most of our providers do not have a direct connection to a QHIO. They connect through their EHR vendor. So they are they're sort of agnostic around like how that works. Would you consider that to be connected to a QHIO if they are not directly? Are you? I guess my question is: are you aiming to limit the point-to-point connections, which I understand, but if they're working through an intermediary, which I think a lot of smaller organizations are probably doing that through their vendor, would that constitute a QHIO connection?
It's a fantastic question. I think for the purpose of maybe just this discussion, I would think of another intermediary as being outside of the QHIO program where we actually require QHIOs to exchange data with one another. So those other intermediaries or services or vendors might be outside of the current program requirements to exchange with one another. But as I mentioned, this type of change would likely require us to reconsider opening applications to allow other intermediaries or vendors to come in and apply.
But just to clarify on that, so was your question, Yvonne, about the EHR part of it? Or?
Well, I mean, I think that it wouldn't make, for at least we would certainly have concerns if every one of our providers was required to have a direct connection to a QHIO, because that would be very different than what they are currently doing. I think it's different to say, we want to limit point-to-point connections. I totally see, why that would be an issue. But if they're working through, if there's another technology solution that kind of gets them to the same place, I guess I'm just.
And then that solution.
What is our end goal with this? Because I think that as it's written now, or it reads that they would need to have a direct connection, we would have significant concerns with that.
Okay, so if the third
they could
party,
connect through
you're
somebody
saying
else,
if the third party could go to the QHIO
like
on their behalf as in their tech stack? Does that mean?
Yeah.
Okay. I feel like that is
so. Just something to. I know I recognize it would need a statutory change, but I think just how narrowly we're defining this and what the end goal is. It's kind of my question.
It's good feedback. Thank you.
All right, Mark, you're up.
Yeah, I'm a little confused. The word forms of exchange, I thought I've heard some of the explanation be around purposes of exchange, like treatment, payment operations, or forms, direct, query, push. So if you could help me understand what you mean, what's meant by forms of exchange here. And then the second question is, would you specify all of the forms of exchange, whatever that means, at one time, or might it be a graduated approach where you start off specifying one, people get used to it, you go to 2, et cetera, et cetera. Thank you.
Thanks, Mark. I can jump in. And for this solution in particular, we are referencing the different exchange types. So that would be query, events, orders, referrals, and information delivery. And in terms of a graduated or phased approach to this, we absolutely we certainly don't think that this solution would requiring all participants use a QHIO for all exchange types, nor doing so all at once. This would be used in select circumstances where the committee and the public thinks useful and necessary to break down those silos.
And it's to address that 45% or 40% that you quoted earlier that aren't in the mix. Like they're doing different types of exchange in their own ways or none at all, but they're not sort of contributing any data or leveraging any data from the other 60%. Is that accurate or no?
That's right. This is largely addressed at those who are selecting, quote unquote, self in the participant directory, who aren't using networks or intermediaries to get their data exchangeable to a broad population and who are relying on point-to-point connections.
Okay, great. Julie.
Yeah, I thought I heard you just say, and I think it's in that first bullet, that it's not all organizations that would be required to participate. So just want to put that pin in. And then also to what Yvonne was speaking to, maybe if we're going to do this, having something that allows them to show they're doing it in another way that meets the same level of the QHIO. So I'm thinking like for social service organizations who are part of 211 San Diego, that might be all they need when you get to that place, right? And that's not costing them any money, or there may be some considerations. So being able to have some kind of justification or coming in. And then in Yvonne's situation, it would be, we're doing it, but we're doing it through a third party and it's still meeting all the requirements. It's just not direct. So it would give you some flexibility in that.
Thanks, Julie.
Ali.
Yeah, so I just want to make sure I understand. This is I think it's the same question Dr. Sells asked. To clarification, this is for organizations, specifically hospitals, for example, that are meeting the DxF requirement through national networks, but not connected to the QHIOs. Is that correct?
So one example of this might look like a hospital who has selected self in the participant directory for event notification. So in order for any participant to access their event notification, they must create a direct point-to-point connection with that hospital directly. So that target population. Now, I think RIM estimated some numbers. I think you said something like 80% of hospitals today use a QHIO for their event notification, but that leaves 20% who either use another intermediary, which is certainly a portion, or select self and require point-to-point connections with them directly.
I feel like there's still like a little bit of a question of like what problem we're trying to solve here, but let's get to Andrew.
Mine's a question of clarification. So if I'm Kiefer Health Plan, under this, I would then have to have a relationship with any qualified, not just specifically one, but any qualified health information organization. Is that right?
No, the presumption here is that QHIOs are required to exchange with one another.
Yeah.
A connection with one QHIO means you have connections to all of the required entities who are using those.
So it's not, we're not designating one per se. It's not, you wouldn't require me to use lanes or manifest or whatever.
That's right. This would be the requirement to use any QHIO.
Any of them. Okay. It's a fair question on the on the intermediaries too, in terms of that. I would also, well, I'll reserve comments for later.
Okay, Aaron.
It sounds like this is really targeted at the ADT conversation. Is it okay? I just want to make sure.
That is it supposed to be? I mean, I wouldn't
not necessarily,
want it
but
to be.
It's primarily what we're talking about, I think.
I think when we open this up for discussion, we'd welcome the committee's both to weigh in on whether you agree with this solution, but also whether you agree with this solution for what participants, with what types of exchange, where would this make sense? Where would this not make sense? So we look forward to that feedback.
Okay. All right. So question, I think to the stats Ren gave earlier was 80% of hospitals were sending through QHIO and 85% of participants were receiving ADTs through QHIO, if I remember right.
Sorry, what was the number you?
80% of hospitals were sending ADTs through a QHIO and 85% of participants were receiving ADTs through a QHIO.
So according to the participant directory, 80% of hospitals that have entered a choice in the participant directory are using a QHIO for that. And according to the recipients aren't in the participant directory as recipients. So that was based on a survey of those that are receiving notifications. 85% of them are using a QHO to get that.
Okay.
So presumably the recipients are not necessarily other hospitals, they're other folks in the network.
Yeah.
For the most part, that was certainly true in the survey. Very few hospitals replied to the survey. So that is absolutely dominated by non-hospital.
Okay. Yeah. And then, sorry, this is just leading up to how I'm going to answer. So math wise, so this didn't include the 500 recent signers because those
numbers were from May.
Were from May earlier. And then you probably can't tell us percentage wise what you're estimating, like how many signers versus non-signers there have been in the state of California yet.
I asked that.
You have maybe too early to say that number. I'm thinking like this 80%, the market seems to have spoken for ADTs, and it's likely that is going to get even further along the lines of closer to 90% either way. I'm just guessing that those who haven't signed yet are likely going to take the easier route of going to the QHIO as they sign up. And that the market is going to further and further lean towards QHIOs for the ADTs.
We're going to, in October, bring the specific signing rates. Getting to the denominators is a tricky task and something our team is actively working on. But I can give you ballpark and high level numbers here. We have today something like 5,400 signatories. The denominator is much larger, in the tens of thousands.
Yeah.
With that said, we have strong compliance rates from organizations like hospitals and plans, and lower compliance rates amongst those like physician organization and medical groups and EMS providers.
Yeah, the people who see the patients.
Okay, that's just showing me where things are going. So thank you. And when we vote, I think when we
signal
when we take our poll, I don't think we're going to be able to say like for which types of services we're polling on, like because I would like to make an answer around ADTs, but
right,
but maybe not other services.
Well, maybe we'll frame the polling on should we like consider this as a potential solution for certain areas, and then we can debate more what, like to your point. Okay, Lynette.
To your question about what is the problem we're trying to solve. So I think that's where I've been trying to think about this question because I'm a state agency. So I don't want to know about 80%. I want to know about 100%. I want to know my whole population, not just part of my population. So I'm not local in one area. our members are throughout the whole state. So if creating some requirements then means that we have the potential to receive all notifications or all instances of conditions that represent medical frailty, or then that seems like that might be a useful thing to be moving towards. I mean, in terms of what is the outcome. We have, if you go to our open data portal and see how many providers are in the fee-for-service provider file, which includes individuals, clinics, groups, et cetera, there's over 200,000. We can't afford to do 200,000 connections. That's not going to happen, right? So the QHIO program essentially gives us an avenue to have connections that then could represent the whole state. And I mean, having been, around this for a long time, California is definitely a network of networks. We've never, been in a position where we've been trying to do something other than that. There's so much variation. There's so much differences. There's different markets, et cetera. And relationships matter, and that figures into trust and other things. So having the QHIO being able to be a complete network would have a lot of advantages in terms of the outcomes we're trying to receive. I'm not sure how that fits exactly into then determining whether we require participant use, because participants go much more broadly. And so, there's a couple hundred physicians that are in a group. And so if the group's connected to somebody, then that gets us there. So it's the details and what it means to require participant use may have some subtlety depending on which of the 7 or 8 groups of participants, like what does that look like?
Right.
Some thoughts.
That's helpful. Yeah, thank you. It does feel like it is important to differentiate like data types and use case. I don't think like any of the vision of the QHA or goals get realized solely through ADTs in hospitals. So like, I do wonder if like, I feel like some of the questioning and comments are a little bit around like trying to interpret what it kind of translates into and means sort of more broadly. So maybe we'll probably just need to think about that part. Yeah. Okay, great. Mark, you're online. You're up next.
Thank you. Maybe this is a different version of the same question, but when I originally read this, I read this as all participants engaging in whatever the specific form or forms. But then Jacob worded something for October in such a way that made me think that it could apply to some categories of participants under the DxF, but not necessarily other categories. The one I have in mind particularly are the CBOs and the social service organizations who a QHIO may not even be the way they're thinking about providing a small set of services. So I think we're in clarifying questions here now. Might this be sorted out by categories of participants, or is this all participants engaging in whatever the specific form of exchange? Thank you.
For this, we're certainly thinking the former, that this would be a solution that might work for certain types of participants with certain types of exchange, but not work for all participants across all types of exchange.
Great, Ali.
Thank you. Clarifying question on the 80%. You mentioned it's the QHIO 80%. Does that include the other intermediaries as well, or just the QHIOs? Thank you. One comment about QHIOs working with social service organization. We do work with CBOs a lot, and most of them are look up in, medical information and relevant information on our portal. But we do actually exchange data in FHIR format with some projects. For example, Project Angel Food is one of them, where we share, they share with us their nutrition assessments and we share with them minimum data required for them to do those tailor meals. So the QHIOs has those type of capabilities. Just since Mark mentioned, that may not be apparent, but it is, and I think it should be a goal of collecting all of this health and social information in one location, or at least in 4 QHIO locations, to be able to exchange across QHIOs and with the providers and taking care of the patients. So I think that's the ideal model. I think that we should evolve to. if the we've seen the outcome of that type of a centralization of the data at the regional level, how impactful that is.
All right, Andrew.
I did have a comment, and I figured it out after I let Jacob's words land on me a little bit more. Setting aside what services are, I did want to harken back to our experience as a health plan. And I think it would lend validity to doing something along these lines. If everybody had to connect to a QHIO of their choosing, that would at a minimum take something off the negotiation plate. So for us, when we're engaging with major systems, you can imagine that there's a lot of back and forth. I have this, I use this thing, you use that thing. This would allow for alignment on a subset of services to be exchanged through a QHIO, where then if you have more elaborate business cases that you're mutually interested in, then you can have the conversation. Is it some bespoke point to point? Or, so I do think there's some validity to this approach in terms of facilitating some baseline level of exchange that up to today is subject of a negotiation that, of course, is in the context of big things like rates and how much people get paid, which makes this a very hard element to even get to, frankly, in those conversations, notwithstanding the fact the law says we have to do it.
Great. Any other? Oh, you're done? Drop the mic. Okay. Okay. And Colleen and Carrie, you are good? It was addressed. Okay. Yeah. Okay. All right. So it seems like maybe a takeaway here is clarifying on what, like you got to it sort of at the end. It could be it could be a participant type and sort of subset of data types. That's sort of like what you're asking. Because if we're going to go to the polling, I just was trying to clarify what we're polling on. And would you state what you would want to poll on?
Yeah, I think
Given the
this
confusion.
Absolutely, this is very intentionally not a vote today. I think what we're hoping for is some discussion on some maybe use cases where this might be useful, if you all think it's useful at all, and then a poll to know directionally which of you think that for any or some participant with some exchange type, this might be useful. So that directional poll, not specifically polling on a specific exchange type today or a specific use case or a specific type of participant. So we're looking just directionally if any of you think that there is some value to this for any participant or any exchange type.
Okay, like is it worth pursuing further kind of thing? Okay, got it. All right, we are going to go to public comment. Is there any public comment in the room? Oh, Deanne, great.
Hi. First one, I'm somewhat rhetorical. I know you don't answer. Clarification to what seems to be a brass ring in listening to a lot of this is the QHIO to QHIO data sharing. As a member who works with a member of the public who works with a number of stakeholders, I think it would be helpful to have clarification of what QHIO to QHIO data sharing is. I know I had one call about 6 months ago saying, what exactly are the requirements, the rules, what is Q to Q sharing? So that's one thing. Switching my hat to a member of the public as a citizen, not professional, we might want to consider the cost impact and the other implications of such a requirement. I'm going to equate it to travel. I want to go to Los Angeles. It sounds like I'm being required to fly one of the airlines, commercial airlines, out of the airport just up the road. I happen to have a private plane. I happen to like trains. I happen to like cars. I've already spent my money on that private plane. And yet it sounds like I'm being required. The only way I could get to Los Angeles is by one of the commercial airlines in the airport. So food for thought.
Okay, do we have anyone online, Akira?
Yes, we do, Dr. Sales. Corey, you can unmute yourself now.
Great, thank you. Corey Mertz from Point Click Care again. We support our SNF customers for their meeting their existing required DxF exchange obligations today, and they don't have to use a QHIO to do that. We certainly work collaboratively with QHIOs. We have existing relationships with many of them and are working to connect with all of them. But we are concerned about an approach that limits SNF's option, any provider's options to use existing non-QHIO intermediaries that they are already successfully using today to meet their exchange needs. And this really feels like it's going to be another unfunded mandate on providers if we're requiring participation in QHIOs when they're already meeting some of their obligations. And then the other thing I would just want to note is, as you're kind of thinking about this, if you were going to go down the route of mandating use for QHIOs for only certain services, it feels a little odd to not go the specialization route as well there, because you're going to be requiring them to use certain services, but you're not going to be allowing them to kind of pick and choose based on specialization. So thank you.
Okay, let's go back in the room.
Thank you. Felix Su with Manifest Medics. We really want to endorse the recommendation, not the recommendation, but the counsel of Aaron on the committee, which is to really focus on, in this case, hospital ADT event notifications. A 20% gap, if that is indeed the statistic, is still untenable when it comes to care coordination and real-world outcomes. This is consistent with the position that we took along with a broad coalition of providers, health plans, and other QHIOs back in 2023 when we asked then CDII to require hospitals to send ADTs to at least one QHIO. Our argument still holds. Guaranteeing that ADT notifications reach the care teams that need them, especially safety net providers that lack the bandwidth to go searching for point-to-point individual hospital connections, it's a collective action problem. It can't be solved through voluntary adoption by hospitals alone, and a modest requirement to route ADTs through at least one QHIO will close this digital divide. And it does so without mandating that any participant use or purchase additional QHIO services beyond that baseline obligation. Thank you.
Is there anyone on the line, Akira?
None at this time.
Okay, let's go back to the room. Hi.
Hi, John Helvey from Sac Valley Med Chair. Sorry I didn't announce my name earlier when I commented. My apologies. But the one thing I would like to address is the unintended consequences of decisions of this committee to the operations of the nonprofit QHOs that exist today. There's a lot of talk about single, there's a lot of talk about QHIO to QHO data exchange. And when there's an imbalance in that ecosystem, it puts at risk those QHIO exchanges that have been invested in so much over the past years with CalHOP and the QHIO program and the EMS and those components. So I would really caution the committee to consider how the decisions you're making are going to impact the existing QHIOs who have a significant amount of data, and how we might be able to balance the ecosystem to serve all of the Californians. So thank you.
Okay, Akira, are we clear on the line?
We are clear.
All right. Jacob, is it you? I don't know. It's me. Oh, we're going to do another poll. Sorry, guys. All right. And Jacob, just to remind people, Jacob's statement was to require participant use of QHIO services for some providers, some organization segment and some type, but not any type.
For some types of exchange, as you guys might have seen, there's a pattern here. These are quite broad solutions that we wanted to just get some feedback on,
Like
see if there's any interest before we actually bring refined solutions to a vote. And so this is intentionally quite broad, and we're not looking for you to commit to having all participants required to use the QHAO today. We're just trying to see if there's interest from this group, if requiring the use of QHAOs for some types of participants for some types of exchange might be of value to the state of California. So that's what we're looking to poll on.
Okay. All right.
Okay, we know what we're doing now, so get those fists up. We'll do a countdown. Everybody ex officio too. Ready? We'll do 3, 2, 1, vote. Okay. We're going to start with ex officio at the bottom this time, just to mess everything up. All right. Let's see. Jared, a 2. Lynette, 3. Shannon. Oh, looks like Shannon stepped out for a minute. Okay. Charles. He's a 3. A 3. Yes? Okay. Amanda, 3. Rebecca, are you with us? She's put 3 in the chat. All right. Now we will go back to our regular voting members. We'll start again at the top. Joan, 3. Bill, 1. Colleen, 3. Yvonne, 0. Aaron, 5. Katie, 5. Andrew, 5. Well, this side of the room. All right. Scott's not with us. Ollie, 5. Oh, Scott is back. Oh, I see Scott. What do you have? A 2 there? Is that a 2, Scott? Yeah. All right. A 2 for Scott. Okay. Eric had to leave for a meeting. We've got Lucy, a 3. Mark, a 4. Yep. Okay. 4 for Mark. Kieran, 4. Dr. Sales, 4. And Julie, 2. All right. Am I missing anybody? Anybody online? Okay. We're going to tally up this poll real quickly. All right. How many zeros did we have? 0, 0. 1, 0. Okay. How many ones? 1, 1. Look at that. How many 2s? Just all of them together. 3. All right. How many 3s? 7. How many 4s? 0. 3. And how many 5s? 4. All right. Well, there we go. We got through that 3 times. Round of applause. Oh, am I missing somebody? Oh, Scott, you need to mute yourself, please. Okay. Thank you, everyone, for going through that with us. I'm going to go ahead and hand it back to Jacob to continue on the last little bit here before we will set you free. Jacob.
Okay, I know at this point you all are ready to get out of here, but we have one more point of discussion as we all look to take this feedback back and do our homework and prep for October. We wanted to open up the floor to hear about other solutions we might research and prepare for that October meeting. So we've talked about 5, 2 that we intend to make, 3 that we had polls on. Are there others? Are there others that you would like this committee to opine on in October? So we'll leave it open at that.
Ollie, this is your, I told you it was later in the meeting. So this is the section where we get to open it up to talk about what solutions would be meaningful that haven't been discussed today, if there are any. And so you spoke a bit about the situation, and now it's like, what would make it better? And you had sounded like you had some other ideas. That's what I was saying. This is your shot.
So we've seen, especially in the last 2 years with the DxF, and participation. Before DxF, we were working with QHIOs and health plans, and I'm sorry, not QHIOs, FQHCs and community clinics, and brought that together. What DxF did is that brought a lot more care providers into the mix, including the CBOs, including behavioral health organizations, and a critical component was the IPAs, that they do a lot of care coordination. And we've seen a lot of improvement and outcome, both in terms of reduction in ED visits, improvement in many other areas that are significant. Patients are being taken care of. Patients are being connected to their primary care providers rather than going to the ER. So, observing this improvement and this outcome, it tells me that, within the QHIO infrastructure, there is a potential to build on that and expand that. And I think that's what we are asking here, is that, and with all the nonprofit QHIOs did this on their own dime. This was not funded. But with additional funding, if there are gaps in the kind of services that QHIO offer, I think we should focus on that, how we can fund the QHIOs to bring, to get to the same level of service that they can all offer and achieve the same results that most of the nonprofit QHIOs have already achieved. But this has been regional. Those are all regional achievements, regional outcomes that shows improvement, and it leads to the reducing the cost. So fragmentation is not going to allow us. It's going to be more expensive. It's going to be more expensive for the providers in order to get the information that they need to take care of their patients.
Okay, so I'm hearing market.
I'm sorry, one other thing is that right now, majority, it was mentioned 80% that's happening right now is with 4 nonprofit QHIOs. Please recognize that. There are 9 QHIOs. How many are they now? There are 8 now. There are 8 QHIOs. Only 4 nonprofit QHIOs are pulling this. And I think the goal should be how we can strengthen these 4 QHIOs to take it to the next level. They've already proven themselves. So how can we take it to the next level? And the next level is that bringing in other non-participants and enhancing the data. And then, the technology going in a way that, with the AI and some of the other advancement in technology, there's going to be tremendous potential if we keep all of this within the 4 QHIOs, and then we'll see the huge improvement in the outcome. In comparison to the other states that was mentioned, I think New York is probably the closest to us, and they have 4 or 5 HIEs that they all collaborate, and there are only 20 million, I think, is the population of New York, and California is 40 million. So with 20 million, they have 4 HIEs. With 40 million, I think we can do much better job, especially coming in late, because it's not about exchanging patient information. It's about how we can make that information actionable. And that's where QHIOs have the technology to make it actionable. What is actionable is that notifying the care provider, notifying the social service organization. That's that care coordination piece. And then, the tools that would help the physicians with, decision support systems that will be coming pretty soon with all this aggregated data that the QHIOs is going to hold. But if this is going to be fragmented, then the information is not going to be reliable as it is right now, because every report that you get, you cannot rely on it because there's some information is missing for the patients.
Okay, so Ollie, I just because in the spirit of this conversation, we're trying to get to other potential solutions that HCI should be thinking about. From a solutioning perspective, what I'm hearing, so tell me if it is that you're saying that funding needs to be addressed and potentially sort of like the business case or markets need to be addressed. I mean, if you're gonna contribute to this question, I do need you to translate that into some forward-looking solution action for us if you want us to do that.
Sure. Yeah, the funding is critical. It's
So you're saying one solution is to fund
the QHIO.
Fund the QHIOs. Okay. And is there any other solution you wanted to put out, or is that the main one?
Make it mandatory.
Make it mandatory. Okay, which we got. Okay, got it. Thank you. Sorry, Mark, you're on the line. Can you read your comment, Mark?
Oh, I can, but that's not really addressing the question before us now. But I'll read it if you want me to.
Oh, I don't know.
Shall,
Apparently, you have to note your comment for the public. So yeah, it'd be great if you'd say it and then get to your solutioning.
Okay. The previous 3 polls, on the third poll, it really helped me to realize that it was a broad proposed solution and there were some variables, and you weren't asking us to figure out the variables, and we weren't, it was okay not to have figured out the variables that would come. That may have been obvious to others, but it wasn't, and that's the reason why I had concerns on 1 and 2 is because there's some pretty serious problems. So it would have been good, like if you'd done an underline or something like that says, we're not filling in this right now. You're just voting on the sort of the abstract solution. So if you're coming back next time with more, that would have helped me to just say, these are variables. We're not filling them in right now. To the question before us right now, I don't really have a solution, but I have more. But the offer of research, I do have a thought about that, which is to pick some really important use cases. I have in mind, for example, the one I mentioned earlier, which is shared care planning among the broad care team, not just the individual care plan between one provider and one patient, but the one that involves the family caregivers, the social service organizations, the hospitals, for maybe a multiple chronic condition use case there, and to try to research that and see what changes to QHIOs would make it better for the broad levels of participants in California to do that. What changes for QHIOs? It seems like a useful set of research from a different perspective for October. If I will throw out one possible solution here that may not make sense, but I personally thought that the REC approach back at the beginning of high tech was a good way to localize, to sort of concentrate resources for broad use, and I thought it improved the whole considerably. Maybe there's a REC solution for QHIOs too that would help increase use and effectiveness. Thank you.
Okay. You got that? Okay.
Julie. REC is regional exchange.
I would love some investigation of a potential solution that incentivizes statewide. So maybe it's, funding subsidies if you can do the whole state for a set of particular activities, kind of to address a little bit of what Nat is saying. Like some of these things are like fundamental. We want it across the state. It would be helpful having it all in one place. So I think something to that extent. You don't have to financially subsidize. It could be whatever. That was just off the top of my head, but some kind of incentive. So when you go out for a bid, there's an encouragement that there's a preference for statewide, and then what elements would be best suited for statewide. And then maybe similar if there's elements that make more sense regional to have those standards as well.
Great, thanks. Shannon.
Hello, speaking from social services perspective, I don't have a recommendation on how to improve the entire framework. But in terms of research in advance of the next meeting, I was talking to Michael about this briefly outside the doors. CDSS is in kind of a unique angle here because social services is not just one program, right? It's a lot of different programs, and there's a different legal framework that dictates data sharing for each one of those programs. And so as I was hearing about how other states have operationalized a data exchange framework or some version of that, it kind of led me down a rabbit hole of like, oh, really, how? I'm very interested in how they kind of managed to integrate social services information into it. And so to the extent that there is capacity, I'd love somebody to dig into like, what does that actually look like, sort of brass tacks when in some of those other jurisdictions? My guess is that a lot of that information is being sort of provided by the individual to their clinician and then added to the case record, and not necessarily this like state level data sharing. But I would love to be surprised.
Great, thank you. Aaron.
Yeah, looking toward October and talking about accountability and these potential changes, and hearing some of the numbers we're talking about, I think it would be nice to understand if the QHIOs today, what that onboarding would look like and the readiness to onboard, whatever those numbers are going to be that we're expecting in a very compressed period of time. Or if we did 5,000 over a couple of years, now we're talking potentially a lot more in 6 months or whatever time period or grace period we're going to give. And are the QHIOs ready and capable of doing that? I think that would be important to know, especially if we're pushing QHIO for certain activities as being like the only option.
Great, thank you. Okay, Yvonne.
I think that for the future I think when we think about that, we've been talking about that, what are that 20% that isn't connecting right now, what those barriers are, and I'm going to guess a lot of it is cost. And we've been talking a lot about funding for the QHIOs, but I feel like whatever happens, like every time you put more mandates on an entity, that cost has to get passed down somewhere. And I think that we haven't talked about it a lot. And I know that it's not very attractive to think like, how are we going to pay for it? But ultimately, as the cost goes, somebody's going to have to pay for it. Everybody's going to have to pay for it a little bit. And as the volume goes up, that cost is, I think it already is real money. I don't want to say it's not real money, but I feel like that barrier is something that we need to, if we're going to be talking about funding it on one end, what are incentives or ways that we can mitigate some of that cost? Or if you want to be a QHIO that, for the smaller organizations, like there's some sort of a cost structure that would make it more feasible and attractive. Because our hope is that, if we have a really great system, people will come and then will want to use it, right? We don't need to force them to use it. So, but I think we have to think about the incentive structure on both ends of that issue.
Okay, great. So you caught that part, incentive on the, okay, Scott, you're online. Do you want something to say?
Yeah, I just think hopefully the background noise isn't too bad, but just future-proofing any decisions we make, because technology is going to change a lot. And a lot of the open standards, such as TEFCA, FHIR, they might provide in the future ADT messaging as part of their suite of options. So we don't want to lock anybody into any technology now that may change in the future.
Okay, so consider technology agnostic solutions. All right, thanks. Okay, others in the room. I have one. Geographic sort of market, a look at geographic like market as a way to organize this network. So thinking so we're hearing a lot about everyone wanting different pieces, but different strengths in different regions. And so, I think it's clear that the all comers everywhere, anywhere with no real business structure around it. It hasn't gotten everything where we want it to be or how it was intended. And so it seems like there's an opportunity to think about, particularly if some of these other solutions would move forward that would require rebid or reapplication, that you're doing it in a little more of a structured way, that's not maybe just anyone anywhere, but making sure there's like the right cover, a certain amount of coverage per region or geography as an organizing principle, which is not sort of inconsistent with way state bids like many services and products. And it feels like that might kind of address some of the minimum, it addresses like quite a few of those issues because you kind of can cut down, you can give folks who have sort of strengths, the strongest applicants, then they have opportunities to really have some market share in those areas where they're strong and they can deliver well, and you can ask more of them, like, because I'm hearing also a lot of interest in not having it be fractured. And so if you want that, then you need to make sure there are solutions that will work regionally. And so maybe there's like a balance there with that. That's mine. All right. Public comment. Do we have any public comment at this late hour in the room? Oh, Dan, really? Okay. All right. Do we have any public comment on the phone?
None at this time.
Oh my goodness. Excellent. Okay. We have a few slides, but we're going to let you out of here after that. Oh, we aren't. What? Okay. Got it. This is me? Okay. So we are on this timeline that you all are familiar with and that Jacob has oriented us to. I think what we're going to do is the team and a few of us will regroup on this conversation. I do think there's probably some things that we'll want to figure out if we can do any interim either touch point or some kind of exploration of. So we'll figure out what's possible in that regard to make sure that we have a really well organized and orchestrated sort of set of discussion items and process for October, given that HCI is really hoping to get some stronger voting and direction in place at that point in time. It also seems like there are many homework assignments. And I think those all make sense. People are sort of trying to make sure they have enough information to be meaningfully engaged in the conversation and feel good about, making recommendations. So I think we'll take those back too. So that we'll be doing some work for the next meeting. And then ideally, I think right here, we're going to, in October, get some direction from this committee in terms of recommendations. And then once we do get to that point, we can talk about sort of what it means to implement them. But we should probably also be thinking about what it means to implement them as we make them, just to make sure they're reasonable. Yeah, okay. All right, so to close out, our last item is general public comment. So you're allowed to do a public comment on any item that we discussed at this meeting, not just the one we covered. I'm also seeing nobody in the room. Akira, how are we doing?
None online.
Okay. Athena.
Just to close out really quickly, we have a reminder for next slide. Just thank everyone for your time today. A little reminder here about the upcoming advisory committee dates. You should have them on your calendar. We encourage in person always. So please do plan to be here October 15th, December 17th, February 18th, and April 15th. We'll get to join you all on tax day. So everybody will be in a good mood. And as you can see, we have our preliminary topics for meeting number 4 there, and we will just continue to move forward on some of what we discussed today and some other hot topics. So always feel free to stay engaged as we are communicating out in between, and we will be sure to see you guys all on October 15th. So thank you so much.
Thank you.